OPHTHALMOLOGICA, and we are welcoming you to the glaucoma session where we have stalwarts of glaucoma from all around the country. Let me introduce everyone one by one. They need no introduction, however. We have on board as a panelist and as a chairperson, Dr. R. Ramakrishnan, Chief of Glaucoma at Arvind Eye Hospital, Tirunelveli. We have our very own Dr. B. Shanta, a distinguished senior consultant at Shankar Nethralaya, Chennai. We have Dr. Ronnie George, Director, Srimati Jadavbai Nathamal Singhvi Glaucoma Services, Shankar Nethralaya, Chennai. We have with us Dr. Sushmita Kaushik, Professor of Ophthalmology, spearheading glaucoma services in PGI Chandigarh. We have Dr. J.S. Bhalla, Head of the Department of Ophthalmology at Deen Dayal Upadhyay Hospital, Delhi. And also we have shortly joining us Dr. Shival Bhartiya, who's a Senior Consultant at Glaucoma Services at Fortis Memorial Research Institute, Gurugram. So we're going to start off with the talks one by one without much ado. And it's my honor to invite Dr. Ronnie George to give his talk on COVID-inflicted changing trends in glaucoma management. So the stage is yours.
Thank you for the kind invitation, Shibal. Can you see my, Saiba, can you see my slides?
Yes, sir, we can.
Yeah. So I thought I'll just speak to you about few things in relation to COVID that we did differently and how things are now. And I basically divide this into sort of three phases. One, the acute COVID phases in both the first wave and the second wave. And phase two is between the two waves and soon after the second wave. And the third is what we're doing now. So I'll just talk about what has changed in terms of history, examination, and practice, and what has not changed. So one of the things that has changed in history is that today we ask every patient a history about COVID, whether they've had it. And if they've had it, then we also look around to see whether there's a history of steroid use related to that or any other significant medical issues they had at that time. The second thing is adherence to drugs. We are all aware that shortly after during the first wave, there were temporary shortages of some medications. And some patients, when you dig into the history, you find they did not use drugs for 3 to 4 months and then came back and restarted using it when the drugs became available. So if you're trying to look for an unexplained progression, asking this is important because you could otherwise miss it. In terms of examination, basically, we continue to do whatever we were doing pre-COVID in terms of vision, refraction, apnation, gonioscopy, disc evaluation. When we started doing visual fields, we started using a tape N95 mask to do it. The OCT, initially we tried with, using cling film over the optics and all that, but we found that it degraded image quality. So we finally started doing OCTs the normal way, disc photos the same way. And of course, there was extremely rigorous sanitization in the first part. We also did a little rejigging of our apnation and gonioscopy in the sense that every glaucoma patient was seen directly by the glaucoma consultant so that this did not need to be repeated by the optometrist and then by us. And of course, the slit lamp shields were a very useful addition, which we put in place, and they continue to be here. In phase two, and currently, we have actually gone back to doing everything as usual, except that fields continue to be done with the taped N95 mask. And we have enhanced sanitization, not really the really rigorous sanitization that happened in phase one. We also started doing teleophthalmology for the first time during this time. At the start of the pandemic, we did not have a system in place, but we do have an EMR, which did not have access to the outside the hospital network. So we set up a system and we used it basically to triage post-op patient and scheduled appointments in the beginning. And basically, this is something like what our interface used to look like. We did have access to patient files. We could go back in the history and see what all had happened to them. And we could do this from both our home or from the hospital. And this was pretty useful. But in the sense at that point in time, we could reassure the patients. We could confirm medication compliance. We could provide alternatives for medication. And we could also send an electronic and SMS or an email with medication details with our registration number, which is actually valid. So this was useful to a lot of patients who could not travel at that time. So in phase one, it was very useful for triaging. In phase two, and currently, there is actually limited value for glaucoma. There is some role in patients who cannot travel or who just have a minor query, but otherwise really not that much use. What about surgery? Glaucoma surgery in phase 1 was limited to emergency surgery. In phase 2, we are doing surgery for all the routine indications of glaucoma, and I'll talk a little bit more about those indications a little later. In terms of surgery protocols, we used a negative PCR for all general anesthesia, N95 mask for all staff in theater, surgical masks for patients. And in phase 1, the only change we really made was in the EOA, we were trying to use a toner pen instead of Perkins, so we don't need to come that close to a patient who's under a mask. But right now, we have gone back to doing everything the way that we were before, continuing to use the N95 mask and negative PCR and the surgical mask for patients. The challenges, real challenges came when we looked at glaucoma follow-ups. And we have, all of us have seen in the last 1.5 years, patients like this, who came to us with uncontrolled IOP or progressing dramatically over the past 1.5 years. And this has definitely added to our surgical load. But we also had patients like this. For example, this is a patient whom just prior to the pandemic, we thought had progressing disease. He had progressed twice, it was consistent. And we asked him for a review after 3 months. Obviously, he could not come at that time and came next almost a year later. And at that time, you can see he's rock solid. It was just fluctuation and nothing else happens. And now we are happier to advise him a slightly more prolonged follow-up because we know he's fairly stable. For this gentleman who's from 1,500 kilometers away with advanced POG in the left eye, stable, but early open angle glaucoma in the right eye, his intraocular pressure on maximum tolerated medical therapy in the right eye, that is this eye, is 16 millimeters of mercury. But as you can see, he has significant progression going on there. And previously, we would have asked for a review after 3 to 4 months. Now we might start discussing surgery because we are really not sure exactly what the future holds in the short term. And for somebody who's so far away and one-eyed, it's a little difficult to make that decision. Or this lady who's an ocular hypertensive, family history of glaucoma, IOP is in the early 20s, so CCT is about 560. She was seen in December 2019 with an IOP of 27. So intraocular pressure sort of had crawled up in the last visit or two to the high 20s. We had advised a 3-month review because she has a fairly strong family history of glaucoma with both her mother and grandfather having glaucoma. And she again did not come for a follow-up during that time. And as you can see over a sort of 14-15 month period, absolutely no change. Absolutely rock solid, pressure staying at that range. And so we are happy to actually offer her a longer follow-up. And we are fairly sure that she is actually fairly stable. So for glaucoma follow-up, we have tend to extend the intervisit duration for long-term stable patients, maybe by 1 month to 3 months in general. Elderly patients with multiple comorbidities, we have asked them to reduce hospital visits. And we've also tried to reduce their exposure by asking for monitoring closer to home. In glaucoma surgery, we have had the same indications as before, but we are slightly more aggressive in persons with poor access to care because we are not sure whether we are going to have issues going forward. So when we look at overall what has happened in glaucoma, we have had a lot of disease progression, and this has translated into much higher surgical rates, partly because of the backlog and partly because patients have not been able to follow up and get appropriate treatment. We have definitely had more lens-induced glaucoma, maybe marginally more neovascular glaucoma. Okay, but what have we learned in this time? What we have learned is that we have become a little better at triaging patients. We're slightly more aggressive, knowing that the future is uncertain in patients where we are worried about vision loss. We're less aggressive in some where we know that maybe even a little bit of fluctuation may not matter. And I think that's the main lesson that we have, that has been re-emphasized to us as we go forward, that we really need to individually look at our patients as individuals and understand that one size does not fit all. So thank you, Saiba, for the kind invitation, and be happy to take any questions or discussion.
Thank you, sir. So there is an audience question. I'll throw that first and followed by the discussion with our panelists. So they ask, are there any long-term side effects of COVID?
For glaucoma?
I'm assuming yes.
Yeah, so not that I know of, but really speaking, nobody has looked at, it's not really long-term yet for us to talk about it. And it's all mixed with progression, non-compliance, loss of follow-ups. Maybe in terms of the increased risk of vessel occlusions in patients with glaucoma who have had COVID, we don't have the evidence yet, but that may be something that we might get, might tell us a little bit going forward. But to the best of my knowledge, nothing.
So have you seen any steroid responders, if at all?
we have seen a few steroid responders, but typically for COVID, what typically happens is soon after they get COVID, they don't come to you. So that's the phase when they've had the really high dose steroids, and typically it's few weeks, maybe at the most 3 to 4 weeks, and they're off the steroid. By the time they come to you is 3 to 4 months, and you don't really see a persistent steroid response. It's difficult to say whether it's the same steroid response or it's just a fluctuation or completely not using medication during hospitalization. These are all difficult to tease out in patients unless you have the medical history.
Arti sir, I would like to throw a question to you. So in Arvind, is there, like sir said, mostly everything is back to normal, how we used to practice? Is there something which has stayed with you? Any trend that was changed and you have caught on to it because it made sense?
Yeah, first of all, thank you, Ronnie, for nice presentation. You have beautifully divided into 3 phases. Acute phase, that's a pandemic, where there was a complete lockdown and all these things happened. And the second thing is in between the first and the second wave. And of course, now the in between second and third wave, we don't know about the third wave, whether it's coming or not. Of course, by God's grace, we don't expect to have that. But in the acute phase, so what we faced, like Ronnie pointed out, one thing is the post-op follow-up. That's one of the things which suffered a lot. So what in our setup, we called all the patients and through phone by phone, and just to give them reassurance and also about the how they feel and all these things, and also regarding the medication, how to use the steroids, and also mainly the other continuation of the anti-glaucoma medication, etc. That was reconfirmed by calling all the patients. And of course, during the pandemic, we didn't have a regular OP, but we had some acute problems, like lentil glaucoma was very, very common at that time, faculatic, facomorphic, and some neovascular, of course. But at that time, we did surgery with all the, because we don't know at that time what to take. So we took all the precautions from the just the entrance to the OT. All the places we had a complete PPE at that time. Everybody was wearing double mask, N95, and also the shield, then PPE. All these things were followed regularly. And the theatre also, only after getting the, because at that time it was very difficult to get the COVID test done, but somehow we were able to manage that and did surgery with all the precautions. And of course, we did admit the patients. Admission was just ask them to come in the morning and send them in the afternoon. That was the thing. Another problem is the examination, as he pointed out, because at that time also nobody was sure about the spread of the virus. Now through aerosol, that's the main thing. So we are all worried about this one. So going near the patient. So mostly we did NCT, and also we had a complete shield between the patient and the doctor. A big plastic click shield was there, and patient also asked to sit a little away. The sit lamp also is very, very brief, no gonio at that time. And of course, we did only NCT, and field and everything was completely, we stopped at that first wave. And of course, the laser are also a little bit we postponed. We didn't do laser iridotomy unless it is strictly indicated at that point of time. But after that, now slowly we have come to almost normal. You asked what's the current situation. Now almost 99% we are back to normal, but we are doing all the precaution measures. We will take temperature and all the detailed history about the COVID, and also the that oxygen, everything we were doing that. But now, of course, the number of cases, everything has come down, and almost now it's normal. But at that time, no, the first one of the thing is the availability of the drug. It's also many people, especially what we see is mostly from rural. So that's a problem. So we try to send through our vision centers wherever possible. We have delivered in the doorstep wherever it's possible only. It's not, sometimes even the drug was not available to us. Just situation sometimes was there, sometimes. Yeah.
No, those are some really real problems, sir. Yes. Ma'am, what about you, Shanta, ma'am? Has there anything that has changed in terms of glaucoma practice for you today?
I think Ronnie has described all the three phases very well, the way we manage the situation. The only thing that we did try was, we used to do these daytime DVTs for patients. They had to hang around in the hospital from 8 to 5. So we tried home telemetry using eye care. So we've done that for about 30 patients. We haven't collected our data yet, but that's one thing which we did a little differently.
Ma'am, may I ask you over here, how comparable is water drinking test with DVT?
I think we published our results in the IJO, and we found that it wasn't very useful as an indicator, as a risk factor showing progression for glaucoma. We didn't find any useful. We didn't find it useful for looking at IOP in patients.
So we'll go on with our next talk. Next, we have Dr. Sushmita Kaushik talking to us about management of congenital glaucomas. Over to you, ma'am.
They're visible, I hope. Yeah, the slides are visible. Yeah.
Yes.
Right. Thank you, Saiban, and thank you for the opportunity of talking about my babies again. So in the next couple of minutes, we'll see what the challenges are and how we go about managing them. So the main challenge is that it's potentially blinding, and our job doesn't end with IOP control, and preserving their long-term vision is the real challenge. So if I can just sum up, one is it's difficult to examine. You have no idea what they actually have. They might just come with watery and hazy corneas. It's a surgical disease, and surgery is difficult in these small elastic eyes. The post-operative follow-up isn't easy, often requires repeated GA or at least sedation. And this is one glaucoma where the goal is not target IOP, but target vision. And there are complex problems with these children, and it's not an eye we are treating, it's a whole family. So you need to bring in genetics, other siblings, the life of the child itself. So taking it one by one, is it difficult to examine? So it's amazing what we can do with children once we put our hearts into them. And these are snapshots from our clinic where children as young as 3 to 4 years will even allow us to gonioscope them if they think we are friendly enough. And this we found very useful. I take pictures of all these little kids on their mother's shoulders, because this zoomed out image is the only slit lamp image or the only slit lamp examination which I can do in some of these kids. So why is knowing what they have important? Because most present with a cloudy cornea. So of course you could have acute hydrops like this, where the mother will come saying that she was fine and suddenly it became white. And that's very amenable to treatment. Do a surgery and they become almost normal. We've just looked at a phenotype called neonatal onset CEO, which is very, very refractory. And this is one prognosticator which you can tell the parents that it's going to be a long drawn, difficult battle, which is very, very intractable. We've learned to recognize congenital primary aphakia and the dangers of surgery. We burnt our fingers with this child, and now we know better how to recognize them. Went into phthisis in 4 weeks' time. And of course, in our country, we can't rule out infection. So if you have a monkey-looking baby like this, look out for cataracts. And it's not just the cataract and the glaucoma, but also sensory neural deafness and the heart defects, which are important. So once we recognize CPA, we recognize many more and realized Dr. Murli from LV Prasad had already published 9 patients in which keratoplasty was done, and 9 of them ended up in phthisis. So these are many more, and we've now learned to recognize the UBM where it's a disorganized anterior segment and there's no lens. What works is a limited diode laser and AFK glasses. So just an example of how recognizing the condition is so imperative to decide how to manage them later. So it's also important to decide what surgery to do. The initial surgery varies. If it's primary congenital or non-acquired glaucoma, usually we do angle surgery if we can see the angle, which is a goniotomy, a trabeculotomy, or combined with a trabeculectomy in case it's very, very hazy. And for acquired glaucomas in children, the usual surgery done is a trabeculectomy with mitomycin because it's not an angle problem. So if treated in time, you can actually hope for a normal child. This is one of the earliest that we've done. Even the vernix is still visible, came to us next morning. She was born a night before, came to us next morning, operated in a day or two, and she goes to school now in about class 2, but still doing online classes. So post-op follow-up needs repeated GA, but do remember that there's a risk of repeated general anesthesia in a small child. So consider sedation. We've looked at dexmedetomidine with a nasal atomizer, and we hardly do GA or give GA to children for an examination anymore unless they need something like a suture removal. So there's so much beyond the IOP. We are in the business of vision. If there's a persistent scar, so you can see this has come down with surgery, but this entails either a PK or an optical iridectomy. We choose our battles wisely. This is an eye which the UBM tells us is going to be very, very difficult features with cataract, with iris incarceration in the cornea. Best left alone, but don't leave alone this eye, which is more amenable. We just did an optical iridectomy for her for lack of eyes, and she's gained very, very useful vision. Now, if the IOP is controlled and the cornea is cleared, but if you have unilateral ophthalmos with high myopia, you're in trouble. So this is a small clip which will show you how difficult it is to even put in a contact lens. She was about -20 diopters. It's very, very difficult. So sometime here is a child with unilateral ophthalmos again. Actually, a refractive lens exchange for -22 diopters, and this boy now has a -4 diopter lens in this eye and is seeing 6.9, where with these glasses he was just 6.60 or even less. So here you can see how the contact lens just pops out once he keeps blinking. So it's very, very difficult to do that, and sometimes you need to think out of the box. So sometimes these children have complex problems. Sturge-Weber syndrome used to trouble us until we just extrapolated the propranolol that is given for infantile hemangiomas elsewhere, and we are happy that propranolol seems to offer much safer surgery in Sturge-Weber syndrome, where we used to see these horrible choroidal effusions earlier. But remember, babies have a life. Sometimes there are battles which we can't win. We thought this was just a Peters and we went ahead and did surgery. But at the time, we realized that the whole lens was incarcerated into the cornea, and sure enough, developed a very unsightly blind eye in this baby. So sometimes you have to counsel the parent. She underwent an ocular prosthesis and he's grown up now. But then remember that they do have a life, and you have a responsibility to see that they're happy as well. A question that plagues us: will my next baby be normal? So this child who went into phthisis when we operated, that's what the parents told us. We actually found an ultrasound prenatal diagnosis of congenital primary aphakia. It's a single case report, and we also did the genetic testing. Yeah, I'll just a couple more. So when we did the genetic testing, it did tell us that she had a FOXE3 typical for CPA, which was likely pathogenic, but they were unwilling for an amniocentesis and genetic test. So we had our hearts in our mouth, but we did an ultrasound prenatal diagnosis of a level 2 ultrasound, and we actually saw the lens placode. So it's possible at 24 weeks to have a lens placode visible. And we just told her that, okay, take a chance, go ahead, fingers crossed. And thankfully, the little sister was born normal. So the responsibility to the family is huge when they come to you. And these are pictures of 3 generations of Axenfeld. The grandfather is completely blind. The father is blind in one eye, but this girl we've managed to salvage because we've come late. It's a hallmark of management. Childhood glaucoma is of all others, but ensuring good vision is our goal. Look out for the family, and we need to hold these children's hands lifelong. Thank you. And I must acknowledge the entire team without which you can't work with these babies at all. Thank you.
Thank you so much, ma'am. Thank you so much for that talk. Let me invite Dr. J.S. Bhalla to give his comments, please.
Yeah, that was excellent talk, Dr. Sushmita, as usual, where you covered the gamut of cases of congenital glaucoma and how beautifully you have managed them. And it's really heartening to see particularly the last slide, where the grandfather and the father were not so lucky enough to have Dr. Sushmita as their treating glaucomatologist, but the daughter really regained her vision. I think hats off to you.
Thank you.
Dr. Shanta, can we have some inputs from you? Any question? Any question from the panelists?
Not really. I think she's covered the entire gambit of management of congenital glaucoma. That it's not just a question of surgery and forgetting about it. A lot of counseling is involved, a lot of long-term follow-up, and it has to be a multidisciplinary approach. Almost all the departments in the hospital are involved in looking after that child.
And probably, understandably so, congenital glaucomas is pretty much confined to institutional practice. So I think there are very few private practitioners, or even in corporate hospitals. I'm not really sure. Dr. Shibal will probably be able to throw some light on that.
Yeah, I find myself very inadequate when it comes to treating congenital glaucomas. As a policy, I try not to touch a baby. I send them all to RP Center because that's accessible here from us. And then a couple have sent to Dr. Sushmita in Chandigarh as well. Some of them will be happy to travel to Chandigarh. It's something I don't do. As a policy decision, it's incorrect, it's unethical, and it's absolutely criminal to touch a baby if you don't have the kind of support that's required. In my setup, I don't have the facility of even a Perkins. I mean, I have to borrow a Perkins every time I need to use one. So it's in so many ways wrong if I decide to touch a child with glaucoma. It's very, very clear. If they're less than 16 years old, they don't stay with me ever.
So Saiban, I mean, I just like to bring in that with justifiable pride now that our senior residents are going out into the region. There are people in Ludhiana, and Gaurav has actually started. He was so happy to share that he's of course doing babies, but he actually did a preterm. So there are a lot of corporate hospitals which actually have ophthalmologists doing ROP. And if you manage to be trained in an institution with that, I think it is also right that you take that training wherever you go, because we need so many to take care of these babies. So he specifically looked out for a hospital with an ROP specialist because he was sure that would have neonatal care and a pediatric care and ROP going on. And he is now doing preterm, and he's doing preterm surgery. So Deepika's there in Hisar. She's doing a lot of congenital glaucoma in Hisar. Gaurav is doing it in Ludhiana. So I'm happy that at least the impetus and the love is going out, and they say when we see a baby, we can't imagine not doing it. But of course, you need to have their back. They know that the minute there is a problem, I will welcome it in the middle of the night. They know that they can send it to me. So if you have that backing from somewhere, it's a great thing, Saiban, that things are finally happening in the private setup as well.
So I'd just like to make one point, and that is that if you're going to do one congenital glaucoma a year, you should not do it. Because
Yes.
this is a surgery just like anything else, where you're required to do a certain number a year to keep in touch.
I completely agree. I mean, I have had my fair share of congenital glaucomas. And the one thing I've realized is that it's just not fair to do them. They are rare to come by for us. And in spite of having an incredibly well-equipped neonatology unit, I just don't have the bandwidth in the ophthalmology department to take care of it. And I just think it's more rational. I understand it loads up all of your systems, and it's embarrassing for somebody who's trained in glaucoma surgery to turn around and say that I don't do congenital glaucomas. But I think it boils down to knowing your limitations within your system.
Yeah, you are correct, Dr. Saibar, because one thing is the anesthetist also. Anesthetist not a anesthetist can give you good anesthesia for babies with congenital glaucoma. They should be very well versed with the knowledge about the congenital glaucoma and IOP during surgery. All these things are very, very important. So this was the one question.
Yes, sir.
Your experience with mitomycin in congenital glaucoma, are you using or no?
Yes, sir. I use them. I somehow, part of me believes that if I'm doing a trabeculectomy in a baby, it's going to fail. I mean, if I have to make a trabeculectomy work, so I do use MMC. I mean, I don't have an RCT with and without. Dr. Mandal doesn't, but then Dr. Mandal stopped using it when he started doing single suture trabeculectomies. I still haven't got the guts to do that as yet. So I do the conventional trab, but I do use MMC.
Okay. What percentage, how long you will use?
Sir, it's the same actually. I use, if unless it is a neonate less than 1 month, then the percentage goes down to 1% for 2 minutes. But if it's infantile, then it is. But so my share of CTT combined trab with trab has gone down drastically once I started with goniotomy 1, 2, even a GAT. So it's very rare that I need to do a combined trab with trab for a smaller baby now over the last year or year and a half. So that's one thing as well.
RT sir, considering the number of camps and the quantity of camps that you hold at your center, is doing congenital glaucomas, managing them, is this cost effective? Is it even taken upon?
In camps, usually in the camps you won't get this type of cases. Usually, mostly it will be a referral cases, especially in the first month or second month. Mostly, sometimes they will come with very late presentation, with advanced ophthalmic eye. Even if they refer, sometimes the parents they won't, because of the poor economical, socio-economical problem, they will not be able to come to the hospital. But mostly they will come in the first or second month of the, even next day of delivery, they used to come. Yeah. Yes.
And Saiban, one point is it's important to sensitize the obstetricians and pediatricians, because all our referrals of early congenital glaucomas are that the bache wale doctor said, better go to PGI today. So there's so many times when the mothers have had a cesarean, they are far away, but the fathers or the daddies carry the baby because it's so precious. Yes. So the obstetrician is very, very, so, like the ROP guys keep talking to the pediatricians. I think we glaucoma guys should also start with the pediatric thing, because then we get them early. Otherwise, it's very difficult.
Yes.
Noted. So we'll move on to the next talk. Next talk is by Dr. Shival Bhartia. We're jumping the two speakers. I'll be speaking in the end. Dr. Deepak Mishra is not able to attend, ma'am. So we'll start with you. Dr. Shival will be talking to us about continuous IOP monitoring. Over to you, ma'am. Ma'am, you're muted.
Isn't it so lucky to be muted when I was saying nonsense? Thank you so much for having me, Saiba. It's a pleasure to be here. And amongst friends, it's glaucoma teachers have now suddenly started feeling like friends because all of these webinars, we've become so just used to talking to them online. I'm going to talk about the dynamic behavior of IOP, and you brought it up forth in the WDT question you asked of Dr. Shanta, but we'll discuss that eventually. We do know that IOP is dynamic, it's individual, and the 24-hour pattern usually has off-hour peaks for most of us ophthalmologists. Almost 70% of BOAG have their highest IOP outside office hours. And in case you will do a diurnal variation in patients, you will end up doing a treatment change. And 20% of NTG patients actually have nighttime IOPs, which are higher than the threshold that's for diagnosis of NTG. And angle closure patients are no different from open angle patients. Of course, the logistics of IOP, costs, access, agreement between tonometers and observers, sitting supine tonometry, sleep laboratories, and cost and access of patient self-tonometry. And like Dr. Shanta, I also use the eye care for my patients during During the pandemic, I have about 80 patients on the eye care tonometry. Interesting readings came from home tonometry as well for us as well. If we were to talk about continuous contact lens tonometry, this is something we've been talking about for almost 10 years now, so it's nothing new. The silicon contact lens with the platinum titanium sensing resisting strange gauges picks up a lot of data, 300 data points, which is a surrogate for IOP, which is not exactly the intraocular pressure. And what it does bring to us is a wealth of data in terms of what is happening to the eye pressure. If you will look as time passes, you'll be able to pick up peaks, and each little data point is an aggregate of 300 fluctuation records from the eye. And this lets you know what is happening in the patient's eye. And as you will notice, almost everyone will have a nocturnal high, which is commensurate with what we already know from sleep lab studies. The clinical experience with the triggerfish has been good reproducibility. Most of the highest signals occur during the night, and prolonged peaks are observed in a lot of patients. Most of them are outside of office hours and has resulted in change in therapy in a lot of patients. But of course, it is as purely repeatable as conventional diagonal variation of IOP. So what's new is what Sahiban wanted me to talk about. So the new thing about the contact lens sensor, which hasn't gone to market yet, is that it is now giving us the absolute IOP during 24 hours as well, which is something we didn't have until now. It measures the IOP, also does body position recordings based on accelerometer readings from sensors, which are based in the recorder as well as the data cable connector. There is a lot of eye blink detection system now, which kind of smooths out the peaks and the troughs. And it is even closer to an ambulatory sleep lab. So the combination of eye blink detection as well as the body position now gives us it tells us more about the eye pressure and what happens to it. Apparently, when you're lying on the left, your eye pressure is the highest. That was a really interesting reading the other day. Also, the machine now has a tool which combines the IOP readings with the sensor, with the threshold file, which you can upload. What is your threshold for diagnosis? To know if the IOP fluctuation has a potential for exceeding a defined threshold, let's say the diagnostic threshold for NTG. So this has incredible potential in terms of telling us which of our patients are actually not normal tension glaucomas. Also, whenever you add the IOP reading, they can be combined as a threshold variable to give you an estimation of the daily variation. So this summary box plot onto the right actually tells you what is the possibility of your patient having a eye pressure through the day of more than, let's say, 15 in this particular patient, or 18 or 21, whatever is your threshold for measuring eye pressures. Haven't had the pleasure of working with the new iMate, but I was part of the team that was evaluating it at one point in time. CE-marked implantable medical device that's put inside either the sulcus, which is like a foldable IOP sensor after you do a cataract surgery, or in the suprachoroidal space after you do your non-penetrating glaucoma surgeries. It has an external handheld reader, which is the power source, and generates the electromagnetic field to power the sensor via electromagnetic coupling. This external handheld reader is also the antenna for sensors. From the sensor signals then come in, can store up to 3,000 individual IOP readings. And the sensor just has to be brought in close proximity to activate the reader. Takes 10 measurements per second. It is now, version 2 is smaller, more pliable, has 4 haptics to prevent any movement in the sulcus. This is the one that you put in after you put in an IOL, and that's how you use the reader to take the IOP measurements. And we've got enough results. ARGOS 2-3 results are out in the public, as is the ARGOS suprachoroidal results. Has shown good agreement with the IOP that is measured during this machine is higher than Goldman applanation IOP. The IOP shows moderate short-term and high long-term variability in most glaucoma patients. The single measurements do not characterize day-to-day variations in IOP. That's something we've known always, but this has confirmed that. And this is really interesting because I think there were 37 patients. This is Kave's study. This has just come out, and it's really interesting to note that these were patients who had the telemetric IOP sensor implanted earlier during their glaucoma surgeries or their cataract surgeries. And they were actually able to acquire their own IOP measurements. And the doctors had access to most of them on their own computers during the COVID-19 lockdown. And they could, titrate IOP to treatment given and actually changed, modified treatment without ever having seen the patient for an intraocular pressure record. I thought this was really cool because we were struggling. I had the one eye care tonometer, and I would have patients, come down to, I now live in a high rise, and they would be coming down to the guard, and the guard would hand them the eye care. They would take the measurement and repeat it and give it back to us. It was like a really primitive way of doing it. And to imagine that you can actually have continuous 24-hour monitoring for your glaucoma patients in case they have the telemetric device, even during a lockdown, was really incredible to read. It was more fun to read than anything else. But yes, the disparities in eye care remain what they are. And the disparities in caregiving remain what they are. The challenges in glaucoma treatment remain what they are, and they're just so much more exaggerated during COVID. I'm just so happy to be here to share this with you. Thank you so much for your time and attention.
Thank you so much, ma'am. Just one quick question from me. So what are the patients, who are the patients exactly that you're doing this IOP censoring for? Would you actually subject an ocular hypertensive also through this drill, or is it just the patients who are progressing and you need to know if there is...
This is basically a research tool. As of right now, it's too expensive to be used in clinical practice. So it's $1,000 per eye per time you do it, just for the sensor. So that's not sensible. That's not something you would be doing in your clinic. If at all you were to use it, you would use in patients who are progressing and patients who you do not know why they are progressing. If their intraocular pressure records, their compliance checks, all of them remain what they are supposed to be, and the patient continues to progress, that's when you put in a contact lens sensor to see what is happening. But a research tool at best. I mean, I would be lying if I said I use it in my routine clinical practice. It's only used when somebody sponsors a study.
Thank you so much, ma'am. Thank you.
Yeah.
There are three audience questions.
Yeah. Dr. Shival, if by using this contact lens fish, what percentage of patients would you think have moved out of the definition of non-intensive glaucoma to open angle glaucoma?
So I am going to quote from literature, 20%.
20%.
20%. Most of these have come in from Southeast Asia. Okay. So 20% have moved out of the purview of normal tension glaucomas because we do miss peaks. I mean, you remember how we do, I mean, you are here in the same city as I, so I know how your residents do your diurnal variations because that's how I did mine. So the patient who was sleeping in the ward was walked to the emergency and then, you did a diurnal variation 2 a.m. record. RP Center doesn't do any nighttime records. They do a 7 a.m. record for their DVT. And at GNEC, we did do a 2 a.m. record, but the patient had walked for about half an hour and was sitting outside while I had my cup of coffee. So I don't know how real that sleep-wake acrophase was actually captured during that record. Now I'm told they kind of, take the sleep lamp to where the patient is sleeping. But still, I mean, once the patient gets up, it's not really an IOP that can be credited to a diurnal variation of IOP in the physiological position. So 20% is what they claim.
Thank you, ma'am. So since we're running short of time, we have 3 audience questions, but I'm only going to post one since this is an answer I also want to know. And I'll throw it to Shanta ma'am first, if you can be kind enough to take it. So it says, how valuable is portable visual fields for home screening and has anyone adopted it?
Which particular technique are you talking about? The iPad?
No, ma'am, we're talking about 3D.
I think at present, they are not equivalent to the kind of analysis that we can get in the hospital. So there is still a lot of variability. There's lack of standardization. So we can't really make any critical decisions based on those devices.
Right.
May I answer that? So Parul's team has just published it from Chandigarh. You might want to look at that study. I think they're in IGO. They've used George Kong's version, the one that's come out from Australia. They've had very good results. And because Parul and I are best friends, I kind of looked at the data as well. And I tried to do the screening as well for my patients. But I didn't end up doing it as much as she did. But she's done and it's a really cool, well-analyzed study that's come out. You might want to take a look at it earlier this year.
RG sir, any comments from you? Whether it can be adopted in the future?
Yeah, actually, we had a very little experience, but our sister in Pondicherry, they have done some work with this portable feed, and they find it, especially they did during COVID time. Yeah, they have done it, and it's, of course, it's not a replacement for complete, but you can somehow see the not progression. You can diagnose glaucoma, what type of field defect and all these things. But the mainly thing is it's portable and it's very cheap, and also you can even a bedridden patient, they can lie down and they can do the field. That's the main advantage of that. We are not doing as a routine because progression analysis and all these things are not possible with that.
Right. One quick comment from RG sir, Sushmita ma'am each, please. I'm guessing this was asked in the context of COVID.
Yeah. So if you're looking at it for glaucoma screening, almost all the perimeters will be reasonably good at giving you moderate to advanced glaucomas. Your early disease is going to be difficult to pick up. None of them have progression software, and none of them are sort of twined with any standard perimeter that will be progression. So you need to keep that in mind, that in your clinic, you need to go with a standard perimeter. If you're going out to the community and you want to look at moderate to severe disease, perhaps. So that's
also the normative data is very limited.
Normative data is limited, and some of the places who are making the instruments actually don't look at the psychophysics behind it. If you put it on and take a look at it, you will see that the screen is actually not without, the screen has a hatched feel to it because of pixels you can see many of the different instruments. So that has an influence because there are straight lines, which is what the brain perceives. I'm sure that has psychophysical implications on the way you look at thresholds. So it's not just showing a light which is brighter and dimmer. There's much more to psychophysics than that. And I think that's something that needs to be understood.
Ma'am, Sushmita ma'am.
Yeah, I agree. I think Ronnie's made a fair point, and glaucoma is all about, I mean, I would be so scared about, I wouldn't bother so much about the early ones, but it is about the moderate and late ones to diagnose. And what I want on a visual field is to see how fast or how are they progressing. So I think Ronnie's been spot on in saying that that is the major limitation. And I think we need to, but yeah, maybe for community work, yes or no, probably suspicious. But then again, a yes or no with a clinical disc examination is so much easier. You don't need a field for that. So in that sense, it's a little limited.
So I'm assuming nobody over here has actually bought it. The marketing has been really poor. Okay. Right. So with that, we'll move on to our next speaker. I invite Dr. J.S. Bhalla, please, for his talk on recent advances in medical management of glaucoma.
Yeah. Thank you. Are my slides visible?
Yes, sir.
Yeah. Yeah. So I'm going, thanks to Sahiban and OPHTHALMOLOGICA team for this opportunity. I'm going to talk on recent advances in pharmacotherapy for glaucoma management. As we all know, glaucoma is a chronic progressive optic neuropathy in which the most common risk factor, the modifiable risk factor, is raised intraocular pressure, and global burden is 76 million in 2020, which is supposed to increase up to 112 million by 2040. So these are chronology of various anti-glaucoma drugs. The first glaucoma drug which made its appearance was in 1875, pilocarpine. Almost 100 years later came beta blockers, then came carbonic anhydrase inhibitors, and then came prostaglandins, and the latest drug which came was tafluprost in 2014, and now for last 5 years we also have ROCK inhibitors. So where is the need for newer anti-glaucoma drugs? We want to improve health-related quality of life. We want drugs which offer neuroprotection, patients with known allergy or side effects to pre-existing drugs. We want drugs with longer half-life, which are more potent with lesser side effects. And there is also need for preservative-free drugs. So these are some of the drugs which have appeared on the horizon, not only abroad, but also in India, although latanoprostene Bunod is still not available in India. And these drugs can be classified into the innovative hypotensive drugs in the form of ROCK inhibitor, A1 receptor and agonist, small interfering RNA, cannabinoids, latrenculin derivatives, K calcium ionic channel modulators, and neuroprostaglandin analogs. And these are anti-oxidative drugs, neuroprotective agents, and also neurotrophic agents. So what is new on the in the medical management? There is latrenculin B, which is actin depolymerizing agent, and it decreases outflow resistance in the trabecular meshwork. And this is a study published which shows that it decreases intraocular pressure by decreasing outflow resistance, and the mean reduction in IOP was as high as 34%. Then we have nitrogen monoxide donors, because as we all know that nitrogen oxide synthetase is found in non-pigmented epithelium of the ciliary processes, trabecular meshwork. And what nitrogen monoxide does is it relaxes the trabecular meshwork cells and also causes vasodilatation and increases the ocular blood flow, and thus improves the RGC cell survival. And the nitrogen monoxide donor is latanoprostene bunod, 0.002%. And because this drug is a nitrous oxide donating compound. And what it does is it has dual action. It not only increases the uveoscleral outflow, it causes decrease in the outflow resistance to the conventional trabecular outflow pathway. These are the studies like Lunar and Apollo, which has demonstrated that OD dosage of LBN 0.024% was not inferior to timolol maleate. And another study, Voyager, also concluded that this drug had better IOP reduction than prostaglandin analog like latanoprost. Then other drugs which have really caused a lot of excitement and buzz is Rho kinase inhibitors. These are considered as novel treatment for glaucoma and ocular hypertension. As we all know, the conventional trabecular meshwork pathway consists of the uveal, corneoscleral, and juxtacanalular pathways. What this ROCK inhibitors does is, we know that trabecular meshwork exhibits smooth muscle-like properties due to expression of both actin and myosin, and ROCK sensitizes the smooth muscle in a calcium-independent manner. ROCK inhibitors target the trabecular meshwork at the subcellular level, binding to the protein which is Rho kinase. And what it does is, as you see in this diagram, at subcellular level, this is the myosin complexes which are at the border of the trabecular meshwork cells. And there is apical localization of the myosin, which causes apical flattening and then apical constriction. So the tip of the trabecular meshwork becomes rounded and the outflow resistance is decreased. So what it does by this subcellular level action is it causes contraction, cell adhesion, and extracellular organization. To understand ROCK inhibitors, we must understand molecular switches, the protein switches, which are known as GTPases. GTPase is considered on when it is bound to GTP, and it is considered off when it is bound to GDP. And what happens is, this Rho is activated by binding of GTP, and ROCK signaling pathways involved in several cellular events, including cell adhesion, migration, differentiation, proliferation, and also apoptosis. So the role of ROCK pathway in pathogenesis of glaucoma is that Rho kinases are involved in calcium-independent regulation of smooth muscle contraction. They have been linked with the control of cytoskeletal dynamics, ectomyosin contractile forces, cell adhesion, extracellular matrix reorganization, and cell morphology. And these factors are known to be determinants of aqueous humor outflow via the trabecular pathway. So they have multiple mechanisms of action. They not only decrease the outflow resistance, they decrease episcleral venous pressure, they cause decrease in reactive oxygen species formation. Netarsudil is one drug which also has effect on the epinephrine pathway. So what it does is, the ROCK pathway causes increase in the intraocular pressure because of increased outflow resistance. But ROCK inhibitors, what they'll cause is, they will definitely inhibit these processes and they will decrease intraocular pressure. They also have effect in modulating the scar formation, and they also help in improving the retinal ganglion cell survival. So besides decreasing the outflow resistance, they are also supposed to be having neuroprotective properties and also increases the ocular blood flow, just like carbonic anhydrase inhibitors. So one drug, such drug is nitazoxanide 0.02%, and other drug is ripasudil 0.4%. But there are adverse effects of these drugs. This is in the form of conjunctival hyperemia, subconjunctival hemorrhage, cornea verticillata, and there is also stringing on installation of these drugs. These are the trials Rocket 1, 2, and Rocket 4. These are phase 3 clinical trials. And yeah, there are the fixed combination of nitazoxanide and letnoprost also in the form of Ropressa and Rocletan. And Mercury 1, 2, 3 trials are particularly for this combination of drug of the ROCK inhibitors along with letnoprost. And now let us talk about prostaglandins. We all know that there are various prostaglandins, and what we have till now done is that there are drugs which are targeting PGFP and PGE receptors, but there are other receptors, also prostaglandin receptors, and so there are drugs which are being developed to target these receptors. And these receptors particularly are PGE2 and PGI2 receptor. Sulproston is PGE2 receptor agonist. So also is butaprost and dinoprost. Then PGI2 analog is iloprost. Then PGF2 analog is latanoprost and Bunod. And PGE2 receptor and E3 agonists are also DE117 and ONO9054, which are also maybe making their appearance in the coming time. So the management of glaucoma looks very promising with the appearance. We have so many drugs which we may for armamentarium for, and also we have prostaglandin sustained release implant. One such is bimatoprost implant, which comes by the name of Durasta, and other is the travoprost intracameral implant in ENV515. Then we have the newer technology to detect apoptizing retinal ganglion cell, so also gene therapy. So I think with these, maybe the medical management appears very glamorous and lucrative. I don't know whether they are going to make surgical management obsolete in the near future, but right now we have so many drugs which I think which will add on to our armamentarium along with the existing drugs. Thank you everyone for your kind attention and patient hearing.
Thank you so much, sir. That was very informative. So we'll go on to the next talk and maybe next take questions in the end for another 1 or 2 minutes. So the next talk is a company sponsored talk, which I will be delivering. And we're going to talk about importance of fixed combinations and their effects on patient compliance and comfort. So this is a company sponsored talk. I'm thankful to Novartis. Hanji. Okay, isn't this a presenter view? You want me to go to the...
Just say use slide. Yeah.
This is better? Okay.
Yeah.
Right. So since we know that our understanding of glaucoma has shifted from glaucoma being essentially an elevated IOP problem to now understanding that it's an optic neuropathy and visual field loss which characterizes glaucoma manifestation, the burden of which is very huge. In 2020, 2.6 billion people above 50 years of age became blind due to glaucoma. And in a study which was done by none other than Dr. R.G. Sir, he pointed out that more than 90% of glaucoma cases in the country still remain undiagnosed. So this is a huge problem. And the patient's journey is very interesting, from telling the doctor, physician, we see these kind of patients every day who come with no symptoms and they say, I'm completely fine. They are unable to accept the fact that they have a problem, which leads to the lack of awareness and the lack of seriousness with their problem. And then a couple of years down the line, they come back to the clinic again with a progressed glaucoma or an advanced glaucoma. And the impact on their quality of life is huge. From day-to-day activities like bathing, feeding, washing, dressing, to even psychological impact like patients get depressed, they are anxious, their mobility is restricted. And there is also a lot of pain and discomfort, and the fact that they can't really look after themselves is psychologically very dysfunctioning for them. So this is just an interesting trivia, no take-home messages from this. I came across while I was preparing for this talk. So there are about 56,000 ways to treat glaucoma, says a certain study. But this is just a fun fact. But again, it does bring our attention to the fact that there are too many confusing regimens out there, which brings down the compliance of the patient. So in choosing the appropriate medication, one must keep in mind that if the cost is minimum and the dosage is minimum, the compliance will be better. So poor patient compliance is as high as even 50%. Patients stop taking their medications at the end of 6 months, was a study done in the US, and a study done in South India by Lee B.W. and Santhan P. said that 74% Indian patients fail to attend all of their follow-up glaucoma visits as advised by the doctor. And okay, apart from the fact that there are real problems that these patients fall out of treatment because of, like cost, side effects, probably difficulty in putting the medication because of rheumatoid arthritis, etc. A major chunk of these patients don't put these drops or fall out of compliance because they don't understand the seriousness, or they don't really understand the nature of the disease. So patients say that we forgot the drop, or I don't understand what it's doing to my eye, etc. So a proper education of these patients is very important. And 50% patients also reported pain and discomfort during their medication. So the kind of medications and the formulation is also very important to be kept in mind. So how do you improve compliance? There are a few strategies: reduce the number of medications, make it easy and not complex regimens for the patient, prefer fixed dose combinations over unfixed combinations, and select a formulation which is closer to neutral pH so that it's comfortable and doesn't sting to the eye. And using fixed dose combinations also limits exposure to preservatives in comparison with component drops used separately. And multiple medications, of course, have their problems. In a study done, it reported that there was a 31% decrease in adherence with patients who were using one medication versus patients who were using multiple drops. So combination therapy is our answer to that, but BS ma'am taught me never start with the combination therapy unless, of course, it's an advanced glaucoma or very high IOP, when you know that one single drop is not going to reduce the IOP less than 40%. Wherein in all other patients, you can keep a time interval with the time interval between the therapeutic incremental steps can be reduced. So these are just some of my own slides to make the case a little more interesting. So this is a 72-year-old male who was diagnosed with POAG 4 years ago, was on prostaglandin analogs for 4 years. His pressure was 17 and 18 on presentation, and untreated IOP was 23, 24, 4 years back. So this is the trend of its visual fields in the right eye from 2012 to 2016. There was a evident progression, threatening fixation. Similarly, in the left eye also, there was progression. The OCT showed thinning and extensive cupping in both eyes. This is how the nerves look like. The nerves look worse than the visual field changes. So in this case, the patient responded well to initial monotherapy, but in spite of a 25 to 30% drop with the PG analogs, the visual field still progressed. So what are our options? SLT may not work very well because this patient has been on PGA analog for a long time. So should I add a single agent or should I add a fixed dose combination? Well, this really depends upon the amount of IOP lowering I require. So these are certain options I have with me. Since the patient is already on PGA analog, I can switch into a fixed combination of a PGA analog with a beta blocker, or I can start a beta blocker in the morning and continue the PGA analog at night, or add a fixed combination drop over and above the PGA analog that he's already using. Now, one must remember that the addition of a single agent to PGA is unlikely to lower the IOP more than 3 to 4 millimeters of mercury, and a fixed combination may be necessary to achieve the target IOP. We have various fixed dose combinations which are available in the market. The new kid in the block is nitarsodil and latanoprost combination. Now, quickly to just understand when we switch, when we add. When your initial monotherapy is working well, it's effective in lowering the IOP, you continue it. But if it is effective in lowering the IOP to the amount that it is supposed to in that class, but you still don't reach your target IOP, you add a second drug. But wherein if in the first place your monotherapy is not tolerated very well, you switch to another class. Now, progression, however, may happen. All right. Progression may happen even in one eye, but it's better to treat both eyes to avoid any confusing regimens. So in this patient, we added a fixed combination and the IOP was well controlled at 12-12. So next, my few slides will be talking about brinzolamide and timolol and how this combination scores over the others. So this is a study done wherein brinzolamide timolol combination versus brinzolamide and timolol separately. So this was a cohort of 174 patients divided into 3 groups and checked at week 2, 3rd month, 6th month, and diurnal variation was done in all of them. So the combination therapy brought down the IOP by about 8 to 8.7 millimeters of mercury, whereas the other 2 component drops in separation were able to bring down only IOP from about to about 5 to 6 millimeters of mercury. Now, this is another study wherein brinzolamide timolol has been compared with dorzolamide timolol combination. And it says that brinzolamide timolol combination is not inferior to dorzolamide timolol combination. However, the difference is probably just it aces in about maybe reducing 1 more millimeter of mercury than dorzolamide timolol combination. Also, it is found that ocular irritation is much less with brinzolamide compared to dorzolamide. And there were more patients who preferred brinzolamide timolol combination to a score of about 79% versus only 21% patients preferring dorzolamide timolol combination. Apart from this, there is also a nocturnal advantage. There is more control of nocturnal IOP with brinzolamide timolol combination versus a brimonidine timolol combination, especially at the time of the night where the IOP peaks the highest. So these are just a few advantages. And however, the take-home message I would like to give, these are a few of my own pointers, how to increase patient compliance. And information leaflet will be very handy. Give time to your patients as well as counsel the relatives. It's basically your approach that makes the patient go ahead with treatment and regular follow-up. So give time to your patient and praise the low IOP that the patient has achieved and praise its effort in making sure that he's put his medications according to rule. So this is just an interesting video, which also brings us to the fact that explaining to the patients how to put their medications is also very essential. So this is a patient from Africa who literally was scraping his ocular surface with the tip of his drop. So naturally, I don't know if he was even squeezing out any medication from there, but it's very important to show the patient, so open up the bottle, show the patient how to put the drops and see if they're able to administer it themselves. Otherwise, they can have a relative do it for them. Thank you. Thank you. So I think with this, we will conclude the session. The next session speakers and moderators already on board. And I thank each and every one, Dr. RG Sir, Dr. Sushmita, Dr. Shanta, Dr. RK, Dr. Bhala, Shibal ma'am, everyone. Thank you so much for being there, consenting to be there. It was lovely. I had a lot of fun. We do have a lot of questions. We will text you and ask you personally and then get back to the audience with that.
Sure.
Thank you so much.
Thank you,
Bye.
Sai.
Thank you.
Bye, everyone. Thank you, Saiba. Thank you, everyone.
Thank you.
Nice to see all our gurus there. And talking about gurus, we have the next session, the Scientist session on pediatric ophthalmology and pediatric cataract. And we have all our gurus on board. We have Dr. Subhash Dade on the panel, Dr. Ramesh Kukinia, Dr. Sumita Agarkar, and Dr. Suma Ganesh ma'am. And we have speakers of Dr. Jethani, Dr. Sheer from Afghanistan. We have Dr. Agarkar ma'am who will be speaking, and then we have Dr. Kekunia from LVPI, and we have Dr. Suma Ganesh ma'am who's going to go first. So ma'am, I think we're already 5 minutes late. So we can, thanks to Saiba.
Did I share the screen? Thanks, Aditya.
This session, we have a small introductory video.
Okay.
So let's continue with our first talk. It's on handling pediatric cataract for children under 2 years of age. It'll be delivered by Dr. Suma Ganesh ma'am. Ma'am, over to you. Ma'am, you're on mute.
Congratulations to all on World Sight Day. What a wonderful occasion and a wonderful program, Dr. Aditya. I would like to thank Dr. Arun Sethi, Dr. Reena Sethi, Dr. Vaibhav and Dr. Aditya for giving me this opportunity on this grand occasion. Congratulations to the Arunodaya Deseret Eye Hospital. So I would be speaking on handling pediatric cataract in children less than 2 years of age. It's not moving, Aditya.
Just click on it. Left click.
Can I stop share and come again?
Yes, ma'am. Please do. Hi, sir.
Okay. In India, 7.5 to 15.3% of the childhood blindness we know is due to cataract. And in India, it is the prevalence of cataract is estimated between 1 to 15 per 10,000 children. So early diagnosis and treatment are of crucial importance to prevent the development of irreversible stimulus deprivation and amblyopia. So a preoperative evaluation and a workup is very essential. We need to know whether it's unilateral or a bilateral cataract, the size of the cataract, and we also need to know the morphology of the cataract and any associated findings like nystagmus, strabismus, if there's macrocornea, microphthalmos, secondary glaucoma, or anterior cerebral dysgenesis. So we need to, in children less than 2 years, most of these will be doing intraoperatively only. And we need to also get an ultrasound done, rule out, because if there is a unilateral cataract, rule out if there is a PHPV or a postal lenticonus. So there are different morphologies you may see in the pediatric cataract. Like if you have anterior lenticonus like this, we have to think of an Alpert syndrome, or we have a lamellar cataract. We have a dense nuclear cataract. We know that the prognosis is not very good because these have very dense amblyopia. Then there could be a membranous cataract and also a postal lenticonus, I think, which Dr. Ramesh is going to speak in detail. So the investigations before surgery are unilateral cataracts. They do not require extensive workup, but in bilateral cataracts, yes, we need to do a torch titers. We need for to rule out Rowe syndrome. We need to do urine amino acids, then serum calcium and levels, urine reducing substance. Of course, we have also started a genetic workup for all familial cataracts. So now the topic is, okay, we have to extract unilateral congenital cataracts by 4 to 6 weeks of age, bilateral cataracts within 6 to 8 weeks of age to prevent development of strabismus, nystagmus, and amblyopia. Do we put an IOL or we leave it aphakic? Or do we... the challenges are the axial length and keratometry change rapidly. The newborn eye has a mean axial length of 16.6 to 17 millimeter. So then more than half of this growth, which is around up to 23.6 millimeter at 15 years of age, it occurs in the first year and more elongation during the first 2 years of life. And we also have a steeper cornea with high keratometry values when it reduces from 51.2 in newborns to 43.5 in adults. So are IOLs good in infants? The infant aphakia study was done. This was a prospective randomized multicentric trial comparing infants who underwent unilateral cataract surgery with either IOL implantation or were fitted with contact lenses without an IOL. They found that there was no difference in visual acuity at either one of age between the two groups. IOL implantation, they found more adverse events like membrane proliferation, like a PCO, like chorectopia, and the risk of glaucoma, they found the same in both the groups. Now, in the Indian scenario, contact lenses, we have a lot of issues like socioeconomic factors, parental reluctance in training and putting contact lenses. Though we have put in few patients who we found that they were not fit for intraocular lenses. And also the problem is non-availability in smaller towns. Then is aphakia. For bilateral cases, yes, it still is the best choice. It is safe, power can be adjusted, it's inexpensive, but we find a lot of abrasions, they're thicker glasses, and there is distortion, and sometimes children don't wear them, and then the children present with nystagmus. So what happens if we put an IOL in children less than 2 years of age? So the challenges are, yes, it is a good option in infants who have anatomically normal eye with no anterior segment dysgenesis, but the problem is the target refraction post-operative and the myopic shift. So target refraction we aim for in less than 2 months children plus 10, 2 to 4, this is plus 9. This is given by the NID et al. Paper which has been published, and we are all following this. And also the IOL power calculation, when we have to do it under general anesthesia. Then we have the reliability of the keratometer and axial length may not be so reliable, but it can be increased by averaging several readings per eye by using the handheld keratometer and the A-scan and the OR. Now, challenges, which formula to use? There are many, there's a lot of literature, and of course, Dr. Kekunia et al. And Dr. Neely et al. Have published that SRK2 is the most predictable in these cases. We have done a study ourselves where we found that we published it in 2016, where with children less than 2 years, we found that the accuracy of SRK-T and SRK2 was comparable, though it was less variable with SRK-T. So we do the SRK-T formula. Then we have an ongoing study which we are doing on the pediatric cataract in infants. What we have excluded patients with corneal diameter less than 9 millimeter, where we do not put an IOL, an anterior segment dysgenesis, or with any retinal pathology. We found the characteristics. What we wanted to study was the characteristics. We found that the keratometry was much steeper. The axial length, there was a variability in axial length ranging from 16.8 to 20. And even the IOL is around 15 to 40 diopters. We found that the variability in the IOL part. So we wanted to study the prediction error, and we found that there was a correlation between axial length and prediction error. An axial length of less than 18 millimeter, we found more prediction error, and we have decided that we would not put an IOL in children less than 18 millimeter. If the axial length is less than 18 millimeter. There's also a correlation between age, like less than 6 months, we found more prediction error, and we also found a more myopic shift at 1 year of age. So we know that the majority of the myopic shift is occurring in the first 1 year of life. Therefore, we need to undercorrect by +6 to +8. So holistic approach is that we just cannot do the pediatric cataract. We need to do a refractive correction. We need to follow up with an amblyopia therapy, glaucoma IOP checkups, need to check for the PCO. In any squint management, we need to do, and also low vision, which completes our pediatric cataract workup. Thank you.
Thank you so much, ma'am, for that very informative talk. Ma'am, we don't have any questions yet in the comments. I'm sure they'll come. I have one question, ma'am. How often do you end up using the UBM, and what cases do you use the UBM as a pre-operative investigation in, say, unilateral cataracts?
We use the ultrasound, and only in cases of pediatric anterior dysgenesis we are using the UBM, because we just have one UBM and it's not in the OR, and so we have to do it in the OPD, and we have to do it in retina department. So we do it whenever we have a doubt and we want to check whether there is, if there is any we want to do a cataract along with just a cataract with a PK, or just optical iridectomy will do along with the PK. If in those cases, mainly we do the UBM. Mainly if I want to rule out whether I have to do actually a cataract or just an optical iridectomy with a penetrating keratoplasty. Otherwise, I think UBM tells us about the posterior lenticonus. So if that is one indication, the ultrasound does tell us about that. And even the axial length, we can come to know with the help of the ultrasound. And I think these are the...
Thank you, ma'am.
Dr. Suma, excellent talk. And,
thank you, sir.
For the sake of audience, what is carry home message for the audience?
The carry home message is that if the axial length is less than 18 millimeter and if you have a corneal diameter less than 9 millimeter, it's better not to put an IOL, because there's a lot of prediction error, myopic shift. It's better to put leave the child a phakic, give the phakic glasses, and plan a secondary IOL later. And the prognosis, even the visual prognosis with the phakic glasses is very good.
Thank you.
I think we can move on to the next talk. Our next talk is on posterior lenticonus pediatric cataracts posed for a special challenge by Dr. Ramesh Kekunia. Over to you, sir.
Thank you so much, Aditya, for this opportunity. I'll be talking about posterior lenticonus pediatric cataracts pose a special challenge. Always it's special. Warm wishes on this special day, the World Sight Day, from all of us from Hyderabad. I would like to give a perspective of posterior lenticonus, both in terms of surgical, visual, and refractive outcomes. I'll just use 3 or 4 slides because of the time factor. One of the things you need to have a perspective is pediatric cataract itself is very, very rare. If you look at this, we looked at 5 years data. We saw 2,286 patients. Out of that, traumatic is 176. And then the posterior lenticonus cases were 84. So the hospital prevalence of pediatric cataract presenting as posterior lenticonus is 4%. So that's the kind of number what you are looking at. So we are looking at something very rare, but for a child, the rarity, nobody tells that it's rare. What the child needs is a good vision. So it's our responsibility. If you see there, 2/3 are unilateral cases and 1/3 are bilateral cases. And there was a discussion on B scan. This is a B scan you can do. You can pick up these cases in most of the cases by doing a simple B scan, and we can do oculizer and other UBM, everything you can use. But I would say clinical and B scan can give a diagnosis in most of the cases. I wanted to give some surgical tips. Just it's a 3-minute video.
So is there an audio also? Because we can't hear them.
Ramesh, audio is not working.
Pardon?
The audio is not coming, sir.
Okay, if audio is not coming, I will
Running
tell
commentary.
about. I will give that. These are posterior lenticonus cases where you can see there is a bulge. That's why your anticapsule becomes flat. So the capsulorhexis, in my opinion, it's not so difficult. And they come in various forms, early dot-like, like oil drop sign, the fishtail sign, what you are seeing here, and advanced cases where there will be total cataract. So in this case, you can see it's total. So they come in multiple forms, unilateral and bilateral. So preoperatively, that diagnosis is important using multiple modalities. Most important, I would say, clinical. In a total cataract, it's better not to do a hydro procedure because sometimes you may not know. In this case, you can see really there is a crater there. You can see that there is a lamellar portion there, and then behind that there is a crater. So routine viscoelastic side port incision, and then what I do is I don't stain these patients. You can see this sheen. It's pretty clear, the sheen of the capsulorhexis. Again, I show that the antricapsule is much flatter. They are not convex shaped. So your capsulorhexis, in my opinion, it's much easier than any other pediatric cataract. I'm talking about anterior capsulorhexis. Once you have that, keep the bottle height down always. The question is whether to aspirate from periphery to the center or center to the periphery. In these cases, I can see all the structures very clearly. I cover the periphery first and then come to the center. That's what I do in these patients. So, and then I implant the lens because this is a big crater there. Once we have done, then we can do vitrectomy and limited capsulectomy there, and then the lens is there. And sometimes it's a total cataract like this. You can even stain the anterior capsule. So whenever you are not sure, stain it and then complete the rhexis. Here you can see there is fishtail sign. What I would do is I will go for the epicenter of the nucleus and I will aspirate everything in one go. That's what I will try to do, because I will manage the peripheral thinner cortical matter later. Obviously, continue with the posterior capsulorhexis. Assess what is the shape. Usually it is elliptical shape. You can still implant the lens in the back. I'll give the statistics of the number, how many patients you can implant. But if you can't, put it in the sulcus and do an optic capture. Both are pretty safe, pretty equally effective procedure. This is what some of the things you need to keep single piece and 3-piece ready, because you will never know. Keep the bottle height down, avoid hydrodissection, outside to in and in to outside. Both the approaches you need to use very, very carefully. That's the video I just wanted to show. In terms of outcome, you can say that around 50% of them get a very good visual outcome. And then 1/3 have fair, because it's unilateral cataract, the outcome is not as good as bilateral. I just wanted to show in this busy table, this is the age of presentation. You can see in unilateral and bilateral, that's different. I think strabismus, it really does not matter. What you have seen is in unilateral cases, they are more myopic than bilateral. Horizontal corneal diameters are much more. Usually they are myopic eyes, if you see the unilateral posterior lenticonus. And the spherical equivalent, the outcome, you can see that it's 2+ in the right eye, in the unilateral, and 5+ in the left eye, in the bilateral cases. In terms of repeat surgeries, out of 84 posterior lenticonus, we had second surgery in 7 of them. And that was like membranectomy and thing. This is interesting. That's what I wanted to show. 1/3 of the patient, or maybe 50% of the unilateral cataract, we could put in the bag. It was possible. Very rarely we could not put in the bag, and it's almost similar in the bilateral cases as well. In summary, I say that it's quite a higher prevalence of bilateral posterior lenticonus. What we see in our cohort, we are even seeing approximately 10% of the bilateral cataracts, bilateral posterior lenticonus, are familial, and we are undertaking genetic study to understand what is the gene affected in posterior lenticonus. That's one of the things we are trying to do now. And the clinical profile of bilateral differs from unilateral, and diagnosis is not always possible clinically. 20 to 25%, we will do it in the intraoperative setting. In the bag, implantation is possible in the majority. However, it's not possible in all. Visual outcome remain fair to poor, possibly due to late presentation and presence of dense refractive amblyopia, especially in unilateral cases. And lastly, I just wanted to show, just remember this. We always have biscuit and chai together. Most of us in India, we have it, and you have to lift it just before it falls. Otherwise, you will have a nucleus drop. Thank you so much, Aditya, for this opportunity.
Thank you so much, sir. I think that was very crisp, and I think you covered all the points. But I would like our panel, Dr. Sumita ma'am and Dr. Suma ma'am and Dr. Adya to give some comments.
Excellent presentation, Ramesh, and what a wonderful videos you have shown. It's a very wonderful presentation. Yes, even we are seeing a very high, most of the younger age group, we are seeing most of them are posterior lenticonus. Now, that's what is very more than the lamellar variety. Now we are seeing most of them are nuclear and the posterior lenticonus type. Though we have not done any, of course, we are doing the genetic workup. And I think you have brought out very valid points that we need to first go and remove the cortical matter from the matter from the periphery and then go to the center. Very nicely covered, very crisp, very nicely covered. I mean, I don't have to add anything. Nice video.
One thing we have seen is that there are patients, they will come with unilateral. After 2 or 3 months, they will come with the other eye as well. They would not have, even they might have a very faint postcapsular opacities. And the other point I wanted to say that this cataract becomes total suddenly.
Yeah,
if you look at the presentation, they will say it's there since 15 days. And most of them, they do not have any kind of nystagmus.
Yeah, suddenly cataract. That's also you have to think of a posterior lenticonus, yes.
One point, I think Ramesh said strabismus did not make any difference, but we published our series of lenticonus last year itself, and we did find a small correlation, a negative correlation with strabismus. But compared to his number of cases, we had more unilateral cases in our thing. So we did find a small negative correlation with strabismus. Those children did a little bit poorly compared to other
cases had esotropia or something. Yeah.
Yes. So children with lenticonus unilateral with strabismus did worse than
they have poor prognosis.
Yeah, they did worse than the children who came with straight eyes.
Dr. Ramesh, it was excellent presentation within a short span of time. But for the sake of audience, I would like to ask 2 questions. One, what were the indications of second surgery in your series? And secondly, what will you advise the beginners or residents to be careful to diagnose such cases at the earliest?
Yeah. Thank you, Dr. Subhash, for that very, very valid questions and kind of comments. The number one is, what are the second surgeries? It was around 10%, less than 10% out of 84 eyes, 7 patients had second surgery. Most of them were membranectomy, 3 patients. 1 patient had an IOL drop because of trauma and things like that. And the other 3 or 4 patients had secondary IOL implantation. These are the indication. And 1 patient had a glaucoma. So these are the indication for surgery. But the resident, I always like that question because Most of the times, as I said in my talk, it's a clinical diagnosis. Acute onset of cataract, that too white cataract in a child, especially unilateral without trauma. Think about posterior lenticonus. Most of the time, through a torchlight, the opacity is more towards posterior. Think about posterior lenticonus. And always, when you order a B scan in a total cataract, always ask for immersion scan so that 90% of the time you can pick up this posterior lenticonus. Patients never will come with the diagnosis of posterior lenticonus. And in unilateral cases, do a vigorous patching therapy along with optical treatment because it's not easy to salvage the vision. Thank you.
Thank you so much, sir. And next up, we have my guru who's taught me everything about pediatric cataract from scratch. Dr. Sumita, ma'am, will talk about pediatric cataract in special situations. Over to you, ma'am.
Aditya, so much. And when you look at actually pediatric cataracts itself is a special situation, and there are so many experts in this panel here who are done some really good work in this area. So if at all, if you have to look within children itself, these would be considered as special situations. So I think there is a speaker who is covering trauma, that is Aditya. So I'm not going to look at infants and trauma, which have been already been covered by speakers before me and will be covered. So I'm going to look at PHPV. I'm going to look at inflamed eyes and sometimes structural abnormalities which require cataract surgery in younger children. So PHPV or PFV can be unilateral, mostly unilateral, but occasionally I have seen it in bilateral cases also. It can vary from a simple plaque on PC to complex formats. Now, complex forms can have stretched ciliary processes, optic nerve abnormalities, sometimes retinal folds and traction. And they probably, nowadays, the newer term PFV includes everything, but probably surgically they are two different groups altogether. Eyes are often micro-ophthalmic, and surgical outcomes can be really poor with high rates of complications. But the recent paper does show that 25 to 30% of the patient you can have some useful vision if operated early and aggressively managed. So I think everybody, even if it's a PHPV, you should offer surgery to these patients and do the best possible job which you can do with these admittedly complex cases. So this is a video of a child with PHPV. She is slightly older. She's been diagnosed at 12, and she's very high myope. And this is one of what I call as simple PHPV. As you can see, after once the surgery is per se not very complicated. She's older also, and you can see here, maybe a little bit later, once the cataract is removed, there is a very, very small plaque here with a and you can see here a plaque with just a very harmless avascular stalk going, and this you can easily cut using a vitrector, and usually does not. I did try first doing a posterior capsulotomy in this, but the posterior capsule is very fibrotic. She was very high myope, so finally I ended up doing with a vitrector only. And after that, it's just a routine surgery, and you can definitely. Compared to this, if you can see, this child has a very, very thick fibrotic capsular membrane. Again, he's an infant. You can see cornea is slightly smaller, and you can have a very fibrosed vascular membrane, which you need to cut using, you need to use scissors, you need to use extensive cautery on these patients to make an opening so that there is no bleeding. But once you have cauterized all the vessels which are traversing the membrane, you can use a scissor and a vitrector together to make an adequate opening as this. This is a very small child, and I decided to leave him aphakic because of very stretched. You can see here there are stretched ciliary processes all around 360-degree. So I did not opt for an IUL in this child. And you can see corneal diameter was just about 9 millimeters. So this would be what I would call as a complex PHPV. Now coming to the inflamed eyes, again, the challenges here are very obvious: poor dilatation, cyclitic membranes, very shallow anterior chamber. You can see areas of Bombay here, there is PS as well as posterior synechiae. So these are the situations where you probably need a good inflammation control. And you must remember that cataract is only the part of the problem and not the problem. So inflammation must be controlled very well, at least for 6 months prior to the surgery. You need a multidisciplinary approach with a rheumatologist if you have a UVA team with them. And you probably need to take their inputs whether these children need a primary posterior capsulotomy and anterior vitrectomy, because some of the pars planitis can lead to a retinal detachment if you do a vitrectomy in these patients. So you probably need to take that call along with your UVA colleague to do a vitrectomy or not at the time of surgery. And there is no ego in saying that some IOL should be probably avoided in certain situations like JRA, where the prognosis with intraocular lens is really poor, despite having some reports which say that they have good outcomes. But if you look at the long-term outcomes, they are really poor. So I would rather not worry about putting an IOL in very very virulent JRA patients. So, but surgical tips, as usual, since dilatation is poor, you need to use hooks, and you may need to cut the cyclitic membrane over the lens before you put the hooks. So sometimes I'm using a spatula here to release the synechiae, but if there are very thick synechiae, you can definitely use you probably better off cutting it using a scissors than trying to use it with. And 26 gauge needle is often enough to put the hooks. So you really don't have to use your 15-degree knife to use it. As you can see, I just used a needle to make the tracks for putting the hooks. And sometimes you may have to use a small rexis first and then go ahead and make another rexis, because these are often intumescent lenses, and you may have to decompress the lens before you proceed, as you proceed with the surgery. And here I have first made a really little, slightly smaller rexis, which allows me access to the lens. And once I have better visibility, I go ahead and enlarge the rexis to allow me to have a fairly, because capsular phimosis is very common, it's not a great idea to leave them with very, very small rexis and requiring a second surgery later. And after that, probably in children, especially because these are likely to have a slightly older children, surgery per se is not difficult. Only challenges lie in getting lens in the bag, and you should definitely avoid putting any kind of lenses in the sulcus in these inflamed eyes. Needless to say, this is just a first step on a very long road, and these patients will need a continuous care even if surgery has gone off uneventfully and you don't expect any trouble, because these patients are more prone for glaucomas. They require care from inflammation point of view, and as I said earlier, here cataract is probably just one part of the problem. So the carry home here is meticulous dissection. Try to, as far as possible, not to manipulate the tissues too much. Make adequate size rexis. Use your UVA team or UVA colleagues' opinion regarding planning a vitrectomy in these children with IOL implantation. Now coming to structural abnormalities, lenticular abnormalities as well as other comorbidities in the eye can affect, like aniridia can have cataracts, colobomas can have cataracts. You can have lenticular zonular abnormalities like subluxation, like luxated lenses and microspherophakias You can have coexisting corneal opicities either due to trauma or congenital where cataract surgery may be required. And of course, sometimes glaucoma also leads to patients with congenital glaucoma also end up requiring surgery. So I'm going, in the short of time, I'm not going to cover many of these conditions, but you need a careful preoperative assessment. Here, there is probably a rule for imaging tools like ASOCT and UBM. They make your surgical planning really easy. Again, I would stress on team approach here, and surgery has to be probably customized and improvised. Corneal opacities, if they are interfering with your visualization, often using a light pipe is very, very useful to look at the anterior chamber while doing the rexis, and it gives you very good visualization inside, even in presence of a fairly dense corneal opacity. And needless to say, again, postoperative care runs in decades and not in months. So this is a video of a microspherophakia child. As you can see, the lens is so mobile. So there is no point in putting Sioni ring 1, 2, 3 and suturing it and putting the lens. This is not going to survive. As you can see, doing a rexis is really difficult because there is absolutely no counter traction to even place an instrument on the lens. And it's probably best in these kind of situation, it's probably best to use your 23 gauge vitrector and use your needle as a cannula inside the lens to kind of give a traction for you to hold the lens while you aspirate it out. And that's what I do. Finally, my cannula is actually inside the lens, and it allows me to hold the lens while I use a vitrector in aspiration cutting mode to remove the lens. And again, there's leaving a clean anterior segment is much better than having a messy surgery with various other attachments in place. Now coming to aniridia, again, this patient has had a surgery elsewhere, and there somebody has put a glued IOL for her, and you can already see there is secondary glaucoma, there is limbus, and this is the other eye of this child, and you can see this eye also has fairly significant cataract. Plus, again, there is secondary glaucoma. You can have, there is a localized fibrotic area here because of the tube which is touching the anterior capsule there of a mammoth implant. And again, here it's very important to do the rexis because that is the most important step which you are going to do. And I almost lost my heartbeat here because that was really a chance of running away rexis at this point, if at all at any, compared to any other point in while doing the rexis. Staining is again very, very useful, and I'm so thankful for having that dye everywhere. Otherwise, here I used, because bag looked fairly stable, I have just put a lens in the bag with leaving my haptics in the area where there is slightly zonular weakness. And as you can see, it looks fairly stable, and tube is also in situ without leaving anything. So again, carry home here is that you need a multidisciplinary approach. That aniridia case I'm co-managing with Dr. Ronnie George, and you need inputs from other departments also to co-manage these cases. And complex pediatric patients, cataract patients, you have to consider yourself only as a part of a larger team, and not really something you're operating in isolation. Thank you very much for the attention.
Thank you so much, ma'am, for that very comprehensive talk and such beautiful videos. I have one question before we go to the panel. We know it's a special situation, and these kids won't recover as quickly as, say, the normal pediatric cataract would. But how often do you need a second surgery or a membranectomy? Just for the sake of counseling with parents, it's good to know beforehand.
Sorry,
How often do you need a second surgery in these cases?
Very often, because these are anatomically abnormal eyes. They are not really normal. There is dysgenesis either at cornea or angle or iridocorneal or something else going on, or a zonular weakness or something. So these patients are prone for you probably are not going to see them very often in your practice. These are very rare cases, but when they do, you often have to not just worry about DBR or just IOL in place or visual axis opacification. You have to worry about several other factors in these patients. And I'm really thankful that they are rare. They are not very commonly seen, where you have to end up requiring surgery. So second surgeries are common. As you can see in that aniridia case, she already has a glaucoma. She already has limbal cell deficiency, and she is going to need at some point some corneal intervention. She is at present, pressures are controlled with AGV, but she's only 8. She still has another 6 decades to go, if not more.
Any questions or comments from the panel?
Sumita, excellent. I have a comment is basically on the cases with JRA. I find them the most, difficult. The surgery is the first part, and I think the most easiest part. The rest of the part is the most difficult because how many times like you felt that you did a vitrectomy, like a small amount of vitrectomy? Because I find that most of these cases, even though they're controlled with steroids, sometimes I have to still ask for a core vit again. So do you plan it with the retina specialist, core vit, or do you feel your vitrectomies?
No, I actually, that's a good question, because a lot of these, I would rather let them have the retina consultant and do a full vitrectomy.
Yes.
Really, JRA patients, I would rather give pediatric ophthalmologists don't touch it, but go to the retina department, do a good core vitrectomy and good lensectomy vitrectomy, because they do best with that. Years of experience after reading the reports of how JIA you can put IOL, finally, long-term outcomes are really horrible. We all know, because we have been managing those cases for 10 years, 12 years at a stretch. So whatever publications may say 6 months follow-up was very good, but JIA or JRA is one thing where with IOL they just don't do well. I would rather not even get into it. Yeah, I would rather pass it on to a retinal surgeon to do the surgery. About the vitrectomy, why I made that point, some of the pars planitis entities where there are vitreous membranes, sometimes we have seen very early retinal detachment when you have done an anterior vitrectomy and actually produce the traction because you have just done limited. Probably those patients will do well if you just do a yak capsulotomy later. Those are slightly older children, and you probably need to do a good polishing so that you hold on to that PCVAO for another 1 or 2 years till they become a little bit cooperative, instead of going on and doing a limited vitrectomy.
Most of the times what we advise is that if we find that the glow is not very good, or we see lot of reflective echoes in ultrasound, then we do ask for the retina also to be with us. So we put the IOL and ask them to do a complete vitrectomy, to do a core vitrectomy.
Yeah.
Otherwise we find that again an anesthesia has to be given for the vitrectomy. They don't do well otherwise.
Yes. So those patients, if you are suspecting JIA, they often don't come to me at all. They go to VR surgeon.
Thank you so much, ma'am. In view of time, being host, I'll go last. So can we have Dr. Jitendra Jithani, sir? He's going to talk about myopia and COVID, what's happening, what's happened there, and what seems to be happening still. I think this is very, very relevant for all our pediatric ophthalmologists there.
Thanks, Aditya. Should I share my screen?
Please do, sir.
Yeah.
Thanks, Aditya. Thank you so much, Aditya, for the opportunity. And I will be presenting some of our work which we did during COVID time. And it was basically on, we all know by now that, we all now know all this fancy extrapolating data from, this has been, I myself have presented this a lot of times that, myopia is progressing at a very significant speed. And these are from Branholden, the article which he published in 2010. And these are some of the articles where they have tried to say that when they have measured near work outdoor exposure and the association between near work activities and myopia, all this all this basically leads us to these key messages that, if parents have myopia, kids are more likely to have it. Outdoor activities do make a difference in growth of the eyeball. Near work amount of light does result in myopic progression, and height increase also correlates with the growth and size of eyeball. This is another wonderful article which I keep quoting. I find it very useful even in my practice that, and the most important key factor here is that low outdoor activities, near work, dim light exposure, low sleeping hours, and reduced reading distance. These are very important risk factors for increase in progression of myopia. So with this background and the background of COVID-2, where it was we went into a very special situation on March 25, 2020, with a view to flatten the curve. The lockdown was announced in India, and obviously this was going to be this was going to increase the hours of reading and screen time, and there was obviously the chance of imminent near work, increased digital screen time. And all this actually led to a concern that there would be a myopia boom across the world. And there have been a couple of studies, not very strong in terms of stats, but there have been a couple of studies where they have shown that myopia has progressed. In our own clinic, we had around 36 children who were being followed up at our clinic since last 2 to 3 years, where they were not having any other treatment except glasses. There was no other intervention being used in those children, especially because we already had suggested them to go for low concentration atropine, but they were not using any intervention. So pre-lockdown, we had already had their set of readings, their axial length, and we followed them up. And this was during the lockdown. So when we compared head-to-head between 2019-20 versus 2020-21, we found that there was a huge jump. And because the data was not normally distributed, we tried to see what was the median. So I'm presenting only the median of the whole data and not really the mean. So the median progression in myopia per year prior to this lockdown was 0.75 diopters, and this increased to 1.25 diopters during myopia. So obviously there was a direct correlation of this myopic progression during lockdown, and this has been not really well reported, but this has been, there was a small letter to editor from Dr. Sumita Mathu, who is a colleague at Narayan Netralaya, where they predicted that there would be a spurt of increase in myopia, which we may see post lockdown. And a couple of studies from Taiwan and China, where they have done school screening, but they did not do the school screening in the same sample size which they had seen previously, but they found that the incidence of myopia overall had increased during lockdown, but they did not do a cycloplegic refraction, and so the chances of children having pseudomyopia may be there, and there was no biometry performed in their particular study. So what we found was that same set of children who were being followed up at the same clinic previous to the year of lockdown, they were assessed post lockdown, and we found that the myopic progression, the rate was much higher. It was almost twice, it was almost doubled. But yes, we had a relatively smaller sample size. There were only 36 children. But since the lockdown was not really predictable and we were not expecting this to happen, we feel that this is quite a relevant amount of data that we have. So we do feel that myopic progression was significant during the COVID time, and more and more patients would be coming now that lockdown has started opening up and patients have started coming up in the clinics. And we do suggest that we should have a national myopia prevention program. It is at this point of time we should think of this in the larger interest of children and future generations. So with this, I end my presentation. And I really thank you, Aditya, for giving me the opportunity to speak on this very relevant topic, especially during COVID times. So thank you so much, and we can discuss it further if you want.
Thank you so much, sir, for that very, very important study. And talking about school screening, I think now since the schools are going to start opening, I think now we'll get the real data going forward. We have one talk from Dr. Sheer Mohammed from Afghanistan, who's joined us from there. And I think we can take both the talks questions after that. We'll be talking about school screening, prevalence of eye disease in children visiting university eye hospital in the first 6 months. So over to you. Thank you for joining us in these times.
Assalamu alaikum. Good evening for everybody.
Good evening, sir.
Thank you so much for Dr. Aditya. My presentation is prevalence of eye disease in children visiting in the University Eye Hospital in the first 6 months of 2020. Outline: introduction, objective, method and material, result, limitation, conclusion, recommendation, and reference. Introduction. Eye disease in children needs serious attention and care because it can affect the growth of education and quality of life in the children. Every year, a large number of children lose their sight due to the various eye diseases and become blind. The majority of eye disease can be prevented from blindness, so they need immediate attention. Timely diagnosis and treatment of the eye disease in children is of great importance. Our objectives: prevalence of eye disease in children visit at the University Hospital in the first 6 months from 2 January to end of June 2020. Method and material. The research design was cross-sectional descriptive study. The research site was University Eye Hospital. The total included cases were 1,429 pediatric patients. The age was 16 and under, who were referred for examination and treatment of the ocular disease within the prescribed period. Age and sex information was collected from the patient file, were analyzed using Microsoft Excel. Patients by age were into the 4 groups: 0 to 1 years, and 2 to 5 years, and 6 to 10, and 11 to 16 years. Inclusion criteria. All patients who were age 16 and under. Exclusion criteria: children 17 years and over. Data analysis. Examination forms were cross-checked from the completeness from data. All data were entered and analyzed using Microsoft Excel. The prevalence of eye disease calculated in the percentage and presented in the table in figure descriptive statistic. In the table 1, list of children distributed by sex and percentage. By 772 and percentages 51.743. Girls, total numbers 657 and percentages 48.257. The most of patients are boys. Table 2, number of patients distributed by sex and disease in percentages. Allergic conjunctivitis, girls 148, 35.40, 40. Boys 207, 17. Percentages 64.7. Refractive error 223, percentages 55.88. Boys 176, percentages 44.11. Total number is 399 and percentage total is 27.92%. Bacterial conjunctivitis, girls 103, percentage 48.35, and boys 100, $51.64, total 213. Percentage 14.090. Blepharitis, girls.
So I'm sorry, in lieu of time, can I ask you to summarize, please?
Okay.
Thank you.
Discussion. Allergic conjunctivitis and UAH, the total number was 1,429 in Calcutta, West Bengal, India, and social India. There is a study, Rami, Salam, Nepal, and Onka, Poya, Nigeria. The allergic conjunctivitis and UAH 25.29%, and India 23.67%, and social India 32.6%, and Nepal 32.6%, and Nigeria 17.8%. Refractive error in UAH 27.92%, and West Bengal, India 14.6%, and social India 31.37%, and Nepal 19.8%, and Nigeria 14.3%. Bacterial conjunctivitis and UH 14.90, and West India, Bengal 15.13%, and social India 8.60%, and Nigeria 15.4%. Trauma in UH 0.76%, and West Bengal, India 12.47%, social India 8.37%, and Nepal 21.7%.
Thank you, sir.
Conclusion. This study showed that the children have a highest incidence of allergic conjunctivitis and refractive error. Boys are more affected than girls. Limitation of study. This research was performed in a small population in UAH. So for their study in the several centers are necessary to obtain accurate result in the country. community.
Thank you so much. I think since we've gotten into the next session time, we have to close the session here. Thank you so much, Suma ma'am, Sumita ma'am, Dr. Kekunia sir, and Dr. Dadea sir, and Dr. Jithani sir, and Professor Sheil sir from Afghanistan, who've taken up time and who's joined us here. I think this is a very nice session. Thank you so much for all the information, videos, and your interactions, please.
Thank you so much.
Thank you.
Thank you, Aditya. We're waiting for your video.
Yeah, I ran out of time.
Yeah, put it up somewhere.
Thank you. Thank you. Over to Dr. Reena Sethi for the next session.
So this session is, Aditya, this session is over?
Yeah, yes, sir. Yes, sir. So please join us for the next session. It's on cataract. Dr. Reena is moderating. Please join us.
A very, very good evening to all.
Very good evening, ma'am.
Thank you for joining us in OPHTHALMOLOGICA. And now we're starting our Novartis session on managing cataract complications. And I'd like to invite our panel here, Dr. Jeevan Tityal, Dr. Mohan Rajan, and Dr. Steve Arshanov, if they're here. Our first speaker is Dr. Jeevan Tityal, and he needs no introduction. He's the chief of RP Center, and he would be speaking to us on posterior polar cataract. Is he there? All right, I think we'll wait for him, and then probably we'll go to the second speaker, Dr. John S. Jasder. Dr. John is in the Florida University. He's a great innovator. He loves to innovate different techniques. And he's going to be talking to us on killing the Goldilocks with the zombie double tap, a cure for top 2 post-op complications of cataract surgery.
I think Dr. Jastad is also not joined. I'll get in touch with both of them and get back to you.
All right, thanks. Thank you. Thank you. So I think we go ahead with Dr. Sibel then. Is Dr. Sibel there? Can you see her, Aditya?
She's there. Oh, wait, I just asked. Yeah, there she
is.
I just left the room for 5 seconds.
Yeah, hi, Dr. Sibel. Good to see you.
Good to see you again. Lovely.
So welcome. Are you ready with your talk on the errors in biometry?
If you want me to, I can go ahead.
Yeah, because the first 2 speakers are not yet ready at the moment. Okay. So over to you.
That was I saw from the agenda that my talk would be later, but I don't mind. I'm fine with that. I can go ahead if you like to.
That'll be great.
So here we are.
So we're really honored to have you, ma'am, here, because your work on biometry is really, we always are in awe how you do it. So over to you.
Thank you so much. And once again, thank you so much for inviting me. I'm really, really happy to be with you. And I'm looking forward to see you live in 3D sometime in this life. So my talk would be briefly about the unavoidable errors in biometry, which are manifold. First of all, you all know the saying, if anything can go wrong, it will go wrong. It's Murphy's Law, which is true for biometry and IOL calculation as well. Let's have a brief look at the theory behind it. The main rule is that any incorrect measurement, either of the axial length or anything, will immediately lead to any error of IOL calculation. And the whole thing is, I will present you many possibilities for errors. They are always only small, but if you add them up, in the end, you might have a big one. So please keep an eye on all the tiny bits and pieces of possible errors and take care of them. Ideally, to calculate in the ideal world, we would need both the radius of the cornea of the front and of the back surface, the central thickness of the cornea, the refractive index of the cornea, and the same data as well for the planned IOL. With those values, together with the information from the industry, we would have everything. And But this would be, keep in mind, this is what we measure now is only the data of the eye before cataract surgery. We estimate by several estimation rules and assumptions, we estimate an eye, how it could be after surgery, but we don't have it yet when we calculate the IOL. That's the bad thing. Another saying I really love is by George Box. He told us, essentially, all models are wrong, but some are useful. And this is true for biometry as well, and all the IOL calculation behind it. So a brief look at all the assumptions and simplifications we use in IOL calculation. Those I will present now are the ones which apply to all IOL calculation models. We assume that the eye length will not change, or that it can be predicted precisely before surgery, and that we know where the effective lens position will be. So where the lens, the artificial lens, will sit in the eye. We only can use the rule by thumb. We don't know it yet because the eye is the eye is not that ready. More simplifications. We use refractive indices, which sometimes are taken from outdated eye models, like the Goldstand eye model is very in favor today still, even if it's more than 100 years old. And for me, a funny assumption or a simplification is to regard the cornea and the IOL as a thin lens, so as a lens with no volume, with no thickness. The benefit is that we only have one radii to recognize and to calculate with. But it's an assumption which might be very, very misleading in special cases like eyes after corneal refractive surgery. Let's have a close look at what we had before. In former times when biometry started, we used ultrasound to measure the eye length. This is today not really the best way of doing it. The optical biometers are more precisely the data can be duplicated by any employee. Everybody can assess this data without any bias. So ultrasound, also ultrasound is a contact procedure. You press to the eye somehow, even if you use the immersion ultrasound biometry, it's not free of pressing, pushing the eye, which makes a difference of the eye length. This is not the fact with optical biometry. Next one, interpretation of the data is also very important. Please keep in mind, we measure something of the eye, and the printout of the machine shows us a number of diopters of the intraocular lens we will implant later. But keep in mind, there is no machine on the whole world available today which measures or which can measure diopters of the eye. It's just a calculation of the radii which are measured and use the keratometer index to calculate the IOL diopter power. And this assumption or this simplification is never correct. It's not even really correct with normal eyes regarding the eye length, but it will be more difficult if you talk about very short or very long eyes. The other thing, which is to me still quite funny because we don't need it today anymore because we have all the data on hand, is the so-called average refractive index. As well, it might be fine for all those normal eyes, the normal length eyes, but it will be very, very misleading with short or with very long eyes. As mentioned before, optical biometers can measure every distance. So there is really no need to use the refractive index anymore, the average refractive index anymore. Regarding formulas, you might be interested. Those we started with empirical formulas. Those are outdated. They are based on big data settings, which are not useful anymore. Today, we use theoretical optical formulas. They should be your first choice. And if you want to do it very modern, use ray tracing methods. They will be the most accurate and precise way of calculating the IOL power. And I love this sentence, one fits all. One of my co-speaker used the sentence as well. This is true for IOL calculation formula as well. There is not one formula on the planet which might be good for all eyes. So there are different formulas suitable for different eyes. We will see it later. The most challenging times are when you have a patient in front of you who had corneal refractive surgery. And here the relation of the anterior surface to the posterior surfaces of the cornea has changed. And classic formulas will never do good in those eyes. So in any case, if you use a classic formula with those eyes, your estimation of the ELP will horribly be wrong. So magic question. I call it the €1 million euro question. Which formula might be the best? What I did for you is I did a small literature search about publications which showed up in 2020 and 2021 about IOL power calculation. And to me, it seemed, or as far as I could see from those key publications, in general, Kane and Barrett formula, you surely know them all, are recommended very often. And they do quite fine. According to our experience at the Institute, the Barrett Universal 2 formula works very well for long eyes, as well as Kane works better for short eyes. Similar to Pereira, I'm citing here on this page. The last publication you can see on my slide, the one by Wendelstein, is talking about the youngest, the newest IOL calculation formula, which I would like to introduce you with my next slide. There are already 2 publications out in the world covering this formula, which also is available for toric IOL calculation formula, the so-called Castrop formula, according to the place where the surgeon lives in Germany, in Castrop-Rauxel. And this can be found also on the IOLCon webpage. We will talk in the next session about IOLCon, the database, where you find all the optimized IOL constants. So biometers from very shortly. There's also a possibility to have an error because ultrasound goes from the front of the eye until the end of the eye, until the inner limiting membrane, the first membrane it hits, that's the distance ultrasound biometry will measure. Optical biometry goes a little bit further. It goes to the retinal pigment epithelium, but in fact, the picture which the brain will create out of the things we see is exactly in between. So both are not really good. There's also another assumption of this distance. Another option which is most of the time not recognized is by those ISO standards we have in place also for ophthalmic surgery. On one hand, the ISO standard defines emmetropia, and according to the ISO standard, emmetropia would be a distance of 4 to 6 meters, which in reality to me makes no sense. Emmetropia is far away, it's about 50 meters outside or more, but not 4 to 6. This is the ISO standard we have to comply with. And the other thing is regarding the IOL manufacturers, there is a quite huge labeling tolerance according to the production of the diopters of their respective IOLs. For example, if you use if you need a diopter, a lens with plus 35 diopters, you have a variability, a tolerance of plus to minus 1 diopter. So in worst case, you are 2 diopters wrong with that lens. And that makes really, really, really a mistake. I was shortly talking about IOL constants. We will introduce you to those constants in the other lecture, in the next session. It's all around that you just try to have as many cases as possible and calculate or calculate your refractive results after surgery for your personalized, optimized constants, because everyone has a different surgical technique. And this may also affect the effective lens position and the refractive outcome of this cataract surgery. So please go for optimized IOL constants. So this is the place, we will talk about that in a separate lecture in the next session. That's the place where you will find or where you can retrieve optimized IOL constants. It's called IOLCon. In former times, you may have known ULIP. ULIP was the old version, but it's not updated anymore. And so since 2017, IOLCon is in place, and you will find all the needed data of also the specifications of the IOLs and everything at this web page. And the most important thing for you as an ophthalmic surgeon is if you go to this IOLCon website and ask for access and submit your refractive data, please keep in mind, this service is free for ophthalmic surgeons. This is an institution of the University of Hamburg, and this is a service to all worldwide ophthalmic surgeons to give support for free for personalized, optimized constants. If you're interested in this database, you will see down here another article. This has been published in a German ophthalmic journal, but it's written in English. So please watch out for this article in the journal called Klinische Monatsblätter für Augenheilkunde. But it's really written in English completely and gives you much more details about this database. So to conclude, one hand, optical biometry should be standard, except of very dense cataracts, very large scars of the cornea, or so on. And please keep in mind, take your time, check out the data, do another test with this eye, do another examination if you're not sure if this is really if this is really good for the eye. Check out for contradictions, check out for consistency, and please use optimized IOL constants. Thank you very much. It was my pleasure, and I hope I kept the timeline.
Yes, you did. Thank you so much, Dr. Sibel. I think it's always anxiety is always there when you're operating on patients and you want to give them the best results. And if you have a biometer that can really calculate and give the best results in, most of your cases, then you're a very confident surgeon. I think that is the basis of our using of newer technology and newer IOLs as well. So thank you so much for your talk.
You're very welcome. It was my pleasure.
Thank you.
Very
So
beautiful talk.
I'm inviting Dr. Mohan Rajan. He's the president of incoming president of TNOA, and a good friend. And he's going to be talking about PCR. What next? Over to you, Dr. Mohan Rajan.
Able to see my screen?
Yes, we are. Now we are. Yes.
Okay, fine. Okay, let me at the outset thank Dr. Arun, Reena, the entire family of the Arunodaya Resident Hospital for the wonderful opportunity. It's always a pleasure to be here in all their conferences, and I'm part of their family and very, very honored to be here. After PCR, posterior capsule rupture, what next? So first of all, anticipate PCR in patients who have got traumatic cataract, post-vitrectomized eyes, posterior polar cataracts, brown cataracts, pseudo-exfoliation. So you know exactly what to do. If you have a PCR, if you have a coaxial irrigation aspiration, coaxial means the irrigation and aspiration are on the same port. What happens is in the PCR, the TAD becomes more and more vitreous gets hydrated, and then more and more vitreous starts coming into the anterior chamber, thus enlarging the tear. And not only that, it will create traction on the macula, traction on the vitreous base, and produce retinal detachment as well. If you have a bimanual means the irrigation is separated from the aspiration, then it's a different ball game, because the tamponates the break and also prevents the hydration of vitreous. It can remove the vitreous which is there in the anterior chamber in the pupillary area. So let's understand this. If you have a small PCT tear, convert this into a posterior capsulorhexis. Why? Because if you have a posterior capsulorhexis, that is definitely more stronger than a PC tear. Now you can go ahead and put a lens in the bag without enlarging this posterior capsulorhexis, because this posterior capsulorhexis is quite strong, just like the anterior capsulorhexis as well. If you have a PC tear, one of the most important things is do not pull out of the eye. If you pull out of the eye, what will happen is, you can see here, the PC tear enlarges, and more vitreous is like a tsunami. More and more vitreous will start coming into the anterior chamber, and you can see the nucleus is also gone in. Immediately I went in bimanual, and remove always the vitreous which is there in the pupil area. Don't be in a hurry to remove the cortex. Fortunately for me, this nucleus popped up, and I was able to remove it and put a lens in the sulcus in this. So when you see a PC tear, as you can see here, introduce viscoelastic through the side port. Okay, this preferably visco. I don't have any financial interest that will stabilize the antechamber, and gentle withdrawal of the phaco handpiece. You immediately create a right side port and do what is called bimanual cortical aspiration. If you have vitreous, that is, put a tricot, preservative-free tricot, you can dilute that and you can remove the vitreous first. In this case, I found the vitreous a little later, but what is important is if you do this maneuver, you can maintain the PC tear. The PC tear in the beginning is about 2 millimeter, and even at the end, it will be the same 2 millimeter because you are not enlarging the PC tear because of bimanual IA, and which tamperates the PC tear and prevents hydration of vitreous, prevents vitreous from coming into the anterior chamber as well. So again, you can see here another patient with the posterior polar cataract. I'm trying to remove the epinucleus, but I didn't withdraw the probe. I injected viscoat into the anterior chamber and gently, immediately put tricot. When you put tricot and go bimanual, immediately, because I use always coaxial, but now we have to go bimanual. Bimanual means the cutter is separated from the aspiration, that is irrigation, or the irrigation is separated from the aspiration. As I told you, always remove the vitreous first and then try to remove. You can use the cutter itself to remove the cortex and the epinucleus as well. That is the cut IA mode or the IA cut mode, whatever you're comfortable with. In this patient, I was able to put a lens in the sulcus and capture it. Again, you can see another patient with a posterior polar cataract, a little older patient, and can see here once I see, typically in the posterior polar cataract, you can see two pillars on the posterior capsule. And once you see the posterior capsule, you can see here, immediately put tricot there. Because the tricot delineates the anterior vitreous, because vitreous is a colorless substance. You'll not be able to see the vitreous unless you put tricot. If you put the tricot, then you can remove the vitreous so easily. And many people, anterior segment surgeons, come and ask me whether whether we have to refer it to posterior. Not necessary at all. Just use high cutting rate and remove the vitreous which is there in the anterior chamber. Once you remove the vitreous, then we inject again viscoat and then go bimanual IA and remove the cortex and the epinucleus, whatever it is. You can see the typical two pillars on the posterior capsule, which is very, very typical of a pre-existing dehiscence in the posterior capsule in the posterior polar cataract. In this particular case, I put a multi-piece lens in the sulcus, but don't leave it in the sulcus like this. Always produce what is called a optic capture. By optic capture, what I mean is the haptic is in the sulcus, but the optic goes into the capsular exit margin, which means that essentially this lens is actually in the back. You can see this, the end point of the optic capture. You can see here there is an ovalization of the anterior capsular axis margin. You can see the ovalization. This is very, very typical. Why you need to do optic capture? Because this maintains the long-term centration of the IOL and also prevents UGS syndrome, secondary glaucoma, uveitis, and all these problems cannot see. You can do vitrectomy through the pars plana. Many anterior segments are not very comfortable. You can do that. You can have an anterior chamber maintainer. You can go measure about 3.5 millimeters from the limbus and go through the pars plana. And you can, just to show you this, this thing here, the vitreous is there in the anterior chamber. You can see here. And what I'm trying to do is to go in and do a vitrectomy through the pars plana, because this patient who had an IOL already, but vitreous is there. You can see the patient was very, very symptomatic as well. And also recurrent uveitis and secondary glaucoma was there. I put an anterior chamber maintainer just to show you, and then try to go in, but you can see the caliper. I'm putting a trocar and cannula and trying to remove the vitreous from behind. It makes more sense to remove the vitreous from behind. Again, you can see the pars plana anterior vitrectomy. Only thing is you need to put a trocar and cannula, make sure that the eye is very firm. Otherwise, it will buckle. If the eye is very soft, sometimes you can have a PCR, you can have the eye can become very soft. And always put a suture, or probably you can put a trocar and cannula and remove the vitreous. Again, to show you that PCR, you can see here, I find a PC tear there. Very difficult to convert this into a posterior capsule because it's extending almost to the equator. So I'm injecting viscoelastic there. You can see the PC tear there. It's a linear type of PC tear. And I'm trying to put a single piece lens in the in the bag. But what happens is, fortunately for me, and the lens is quite stable, but the PC starts enlarging. So if you don't have a capsular excess, posterior capsular excess, then you can probably this thing. Just if you have a PC tear and you can see this. This will show you the anterior-assisted levitation. With the PC tear, nucleus goes in, then anterior-assisted levitation you can do, or a posterior-assisted levitation. And this patient, I put an anterior chamber IOL just to show you that take-home message is very, very important. The preferred practice patterns would say small PC tear convert into a posterior capsular excess. Do not pull out, inject viscoat, use tricot preservative-free, bimanual automated anti-vitrectomy. Don't use sponges or don't use devaker scissors, limbal or the pars plana, which are comfortable. Remove the vitreous first and then remove the cortex and epinucleus, appropriate IOL, whether it's the small PC tear, you can put a single piece lens in the bag, or if it's a large PC tear, then you can put probably in the sulcus, or even if you completely lost it, they can probably go in for a iris claw lens, posterior chamber, or a glued IOL or a sutured sclerotification. Always I prefer to suture the wounds because the incidence of endophthalmitis and the PC tear and the vitreous loss goes up very much. Thank you again, ADEH, for the wonderful opportunity. It's always a pleasure being here.
Thank you very much, Dr. Mohan Rajan. It was a wonderful presentation, brilliant videos, and very good tips, especially for PCR. It's very important to be there and have all your pointers ready and your black box ready, because just in case you need something from there, it has to be all ready. Thank you very much. Thanks a lot.
Thanks a lot, Reena, for the wonderful opportunity. It's always a pleasure being coming to ADEH and presenting.
Thank you.
Webinars.
Thank you. So I'd like to invite Dr. Ehud Asya. Dr. Asya doesn't need any introduction. He's a very, very famous personality in ophthalmology. And we've had the privilege of going to Aintal and visiting his institute. It was a pleasure because he's way, way ahead in technology. So over to you, Dr. Asya, on your newer second generation capsular anchor.
Well, thank you very much, Reena. Can you hear me now?
Yes, we can.
Yes.
Okay, good. So it's a pleasure to be here again, and thank you for the invitation to participate in your wonderful webinar. And hopefully we will start meeting in person again. We are just 2 days after the ESCRS. So it's a start. It's not full scale, but we are back to frontal meetings. So hopefully we'll meet in person quite soon. So yes. I would like now to share with you our initial experience with the second generation of the capsular anchor. And these are my disclosures. The one with Hanita lenses is the one which is relevant to this presentation. The capsular anchor is a device that we designed several years ago for positioning and for securing the subluxated capsular bag. And the idea is it works like a clip. It's actually a capsular clip. These two lateral arms are positioned behind the anterior capsule. The central part, the central rod, is in front of the capsule and it is sutured to the scleral wall. And this provides stability. And we have demonstrated and published how we can use it either for crystalline lens or for repositioning and fixation of eyes with subluxated intraocular lenses. And these are some examples here. This is the patient after trauma. The zonules here are missing. And we see that after using the anchor, the IOL is back in place and very stable. And here are some more examples. And we have tens of these eyes, and it works very, very effectively. If there's a large zonular dialysis, we can use 2 anchors. Actually, we can use even 3 of them. In the cases in which most of the zonules are missing. And these are some eyes with subluxated intraocular lenses in which we use the anchors. On the left is my case, on the right, Mike Snyder, and we have some of these cases. However, the first generation of the anchor was kind of a bulky. It was a thick, not very flexible, and uniplanar, which makes it quite difficult to manipulate. So we developed a second generation of the anchor, which make it much easier to use. And the main change is here. This is what it makes it 3-dimensional. It's on 2 levels. and the two arms are much more flexible. So this is when we compare the first generation on the left and the second generation at the center, we can see it is much easier to manipulate, to bring the capsule in place and to manipulate the entire device. So we started with operation of 10 patients. 8 of them were crystalline lens and 2 with IOL. The cause of subluxation were usually either trauma or pseudoexfoliation, myopia, and Marfan syndrome. And let's see some of these cases. So first of all, let's see the device. We can see when we put it on the profile that it has 2 levels. It has a 3-dimension, unlike the previous one. And this is in a pig eye. Just for demonstration, we put it in, we place the anterior rod on top of the capsule and just push forward. And that brings it right into place. We can also insert, when the 2 arms are pulled together, we can insert it through a porosynthesis of 1.5 millimeter and use it in a similar way. This is a patient after trauma. We do the capsulorhexis first. The lens is quite soft. So first we insert the needle and externalize a 6-point suture. We thread the suture through the hole at the base of the anchor and then create a flange. We must make sure that it is large enough so it will not flip out, and then place the anchor just on top of the capsule and just push it forward. And note that in this case, the positioning of the anchor was done before the lens removal. So we actually use it like we use iris hook or capsular hooks to stabilize the lens during the lens removal. Now, when it is in place, we can do the phacoemulsification, remove the lens material, and then clean the capsule and implant an intraocular lens, and the long axis of the lens is pointing towards the anchor. And only now we make the final adjustment and make sure that the IOL is in place and it's well centered. And this is the end of the case, IOL stable. We can see here after 1 month, the inferior anchor, the inferior flange, which is covered by the conjunctiva. And this is another case which is also post-trauma. We do the capsulorhexis. In this case, the lens was stable enough so we could actually remove the lens material before implanting the anchor. And now after the nucleus is out, we thread the 6/0 through a porosynthesis, externalize, thread it through the base of the anchor and create the internal flange. Then insert the anchor into the eye, and you can see this is a low profile. It goes easily through the opening of the phacoemulsification. And then when the capsular bag is evacuated, it's very simple to put it in place. And after the IOL is in place, we create the external flange. This patient also has a fixed dilated pupil, so we now push the pupil down, also suture it to create partial pupilloplasty. So the patient would not suffer from the glare. And now after 1 month, we can hardly see where the anchor is, but with retroillumination, we can see the anchor in place, and it's actually stabilized both at the capsulorhexis edge and at the equator. So the entire segment is stabilized by the anchor. And this is a patient with unstable intraocular lens. First, we create a pocket superiorly, insert the first anchor, place the 2 lateral arms behind the capsule, and then fixate it temporarily to the scleral wall. Then do the same inferiorly, open a pocket. We do not need to open it all around. A pocket is just enough. And this is what the difference between anchor and the Sioni ring or Malyugi ring or any other type of ring. So now, when it's in place, we finalize the flanges, and we can see that indeed the 2 anchors are in place with the 2 arms located behind the anterior capsule. And at the end of the operation, the IOL is centered and stable. So this is our clinical result. On the left, we can see the visual acuity before surgery, on the right after surgery, and 7 out of these 10 had visual acuity of 20/25 and better, 6/6 in both sides. And this is another case with malpositioned crystalline lens after fixation and at 1 month. Here we can see again the stability of the IOL on the left, and on the right with this oblique view, we can see that it's fixated both to the capsule and to the lens equator. So it does provide a very wide contact of the device with the anterior capsule. So just to summarize, the capsular anchor is effective as a stabilizer for a variety of lens subluxation, either crystalline or subluxation of intraocular lens. And this modification of the anchor to generation 2 does provide significant improvement in terms of safety, efficacy, and simplicity of implantation. And thank you very much again. And once again, thank you for the invitation. It's a great pleasure and honor. Thank you.
Thank you, Dr. Asya. I had the honor of using your the generation 1 anchor. And I just want to ask you, this definitely looks much smaller, and it looks much easier to use also, because that requires a lot of threading, and then you need to tie it and make a pocket and all of that. What is the incision size that you recommend for putting it? Is it just 2.2, or do you need to enlarge the incision to put this anchor in?
0.2 is sufficient. 0.2 is sufficient, and one can also manipulate the two lateral arms. So 0.2 is sufficient. We do FACOP 2.2 or 2.4, so this is always sufficient. But in case of using this device for subluxated intraocular lens, then one can do between 1.5 and 2, and it will go in. And
in your practice, how many of these have you implanted in one patient? I mean, the maximum that you've done for one patient?
So far, 2.
Thank you so much. Thank you very much. So we're looking forward to using this as well.
Okay. Hi.
Hi, Mohan.
Hi. How are you? Yeah, it's always a pleasure to listen to you. What are the dimensions of this anchor? What are the dimensions?
The maximal is about 2.5. That's the maximum when it is full. But so it can go easily through this incision, and it occupies about an hour and a half of the circumference. Okay. So if you make a 2-hour kind of a pocket, that's all you need to insert it.
Very good, sir.
Thank you. Thank you so much. I think we have Dr. Jeevan Tityal with us. If he's ready, we can call him up next.
Hey, I'm there.
Yes, thank you so much, and welcome, Dr. Jeevan Tityal. Dr. Tityal needs no introduction. He's the chief of RP Center, and always a pleasure. He's a great teacher, and we love to listen to him. He's going to be talking to us on the posterior polar cataract and its management. Over to you.
Okay, just let me open my presentation first, and many congratulations to the entire team doing such a wonderful session. I heard beautiful talks, which it's a really eye-opener to listen to such experts talking on to the various aspects. I'll be talking in the more routine thing, which we all do, and we all face the posterior polar cataracts. No financial disclosure from my side for this particular talk. We all know posterior polar cataract would definitely impose threat to your surgical technique on the table. And sometimes we have to pre-counsel the patient that the entire plan might change during the procedure itself because of the support may not be available to put the right decided IOL in these cases. The step which is much more worrying is the step where we actually remove the epicortical cushion in these posterior polar cataracts, when the actual dehiscence of posterior capsule might happen in those cases. The examination part is very important, and we know that routine good examination with slit lamp will give you all the details required for posterior polar cataracts, especially the size of a disc and the extension of disc towards the anterior posterior wise is also very important. The hardness of nucleus is also a very significant component. We know that larger the disc, harder the nucleus, we're going to have more challenges in nucleotomy, and chances of posterior capsular dehiscence will be much more. This is a type of posterior polar cataract where we know that there's a pre-existing posterior capsular defect in these cases. These pictures can be very nicely highlighted with anterior segment OCT, and you can change your plan accordingly. Looking onto the surgery wise in these cases, we know that classical surgery would be to do a slow motion phaco in these cases, where your parameters are absolutely normal, for which you have been practicing for a long time. Capsular access, there should be no debate. It should be as routine as possible, around 4.5 to 5 millimeter, which in some cases where if you have posterior capsular dehiscence happening and support is not available, this can be used for putting a lens in the sulcus and getting optic capture in the anterior capsule is a very good way to look into these cases. So here I'm doing a capsular access of around 4.5 millimeter. This is a classical posterior polar cataract with the disc is around 4 millimeter. The idea here is to decompress the antechamber, remove viscoelastic, delineate the nucleus core. This is the two delineation I have done. So this will customize the epicortical cushion in these cases, and subsequently just decompress from a periphery so that you don't have a pressurized bag at this time. So we are going to do a phaco, which is softer in most cases in a posterior polar cataract. Rarely we see a very hard cataract in this case. So this is a absolutely soft cataract. I'm going to do a little sculpt in the center, which gives a extension of your core of a nucleus to a periphery, which you can just sculpt like you do a routine soft cataracts. So I'm taking out the primary epicortical area now because the nucleus has already been taken off. This is the first delineation, which is I'm going to take away, which is basically the nucleus core. Now I'm going to the periphery. That's a second delineation. You can see this is the second delineation I'm taking off. This will leave the posterior cortical support behind. But at this stage, you have to be very, very careful to aspirate very slowly, because most of the time we don't do hydrodissection posterior polar cataracts. There, if you are lucky, there will be internal hydrodissection happening in most cases, which will allow the safe removal of epicortex in these cases. So this is how our case will end in most posterior polar cataract, and successful implantation can be done. This is a cortical removal which I'm doing. See here, I'm taking out the cortex from periphery, leave up to the center, and allow the fluid to seep through the central area, because that's the area of concern for all of us. Once we take out the cortex from periphery, leave to the center, so you can aspirate the entire block in these cases. In case you have a posterior capsular deficiency happening this stage, you can still manage very effectively in these cases, because most of the cortical matter would have been aspirated. Luckily, in this case, we didn't have any defect, so you could implant the desired lens in this particular case. So this is a normal case of posterior polar cataract, which normally would work out with a proper examination in these cases. But what about the intraoperative decision making if you have IOCT? This is what we published, the classification and dynamics of posterior polar cataract on the table with IOCT. So this we graded as a type 1 posterior polar cataract, where you could delineate the entire length of a posterior capsule from the disc to periphery also. This is a type 2 where periphery of a posterior capsule can be clearly delineated, and central area it cannot be delineated as such. And type 3, where the entire length of posterior capsule cannot be seen. This implies that your disc is larger, thicker, or your nucleus may also be much more harder. So these cases will have a higher chances of defect happening in your procedure. And this is what we talked about. We all see a posterior, you can say, cortical disc defect happening in all type of posterior polar cataracts. So this, we call it an intraoperative posterior polar cortical disc defect, or a PPCDD. So that's an acronym for a posterior cortical disc defect happening during the surgery for your cases. The donut-shaped opening is seen classically in these cases, and the size normally corresponds to the size of disc you have. So if you see this video here, you realize this disc, which is seen clearly in our IOCT also. You can see the posterior capsule is well delineated. I'll just go a little fast forward here. You can see I've done a hydrodelineation. The two delineation can be seen clearly with the IOCT, and decompression will take out the fluid, and that will decrease the pressure onto the posterior capsule access. Simple stop and chop technique being used for anechotomy, which is applicable for a slightly harder nucleus, like in this particular case. because we have not done a hydrodissection, nucleus rotation can be difficult sometimes. If I take out one piece of nucleus, the subsequent nucleus, there's an internal delineation happening through the earlier delineation we have done, and subsequent things becomes easier. So this is the stage where you can see the defect appearing because I'm removing the epicortical support from these cases. Once you see this defect, sometimes we feel that the posterior capsule may have given way. But actually, this is not true because most cases, the posterior capsule will be absolutely intact. If you see IOCT here, I can clearly see the posterior capsule in this case very, very clearly, and little cortex in the periphery. If you see, this sign signifies that you have an intact posterior capsule in these cases, and the amount of cases where we see this sign is around 90% of cases we see PPCDD, and it appears normally after epicortical removal, majority of cases after cortical aspiration. There are some cases where you don't see this defect. In those cases, you may have addition of a disc into the posterior polar cataract capsule, and you can have high chances of capsular tear happening in these cases. If you don't see the defect, you have a high chances of posterior capsular defect happening in these cases. So that's a good sign that PPCDD is going to give you a safe surgery in the posterior polar cataract. You can see around 87% of cases we could see a classical PPCDD, and most commonly it is observed after epicortical plate aspiration. Incidence of PCR in these cases is 0. But if you don't see the PCDD, then you have a higher chances of PCR happening. Around 40% of cases will have PCDD. So this is what I normally talk about. The surgery is simpler in posterior polar cataract if you do a good pre-op analysis. If you have access to entry-segment OCT, that will delineate much better. But if you have an IOCT microscope, intraoperatively, you can stage every step of your surgery, especially the hydrodelineation, and you can titrate the epicortical cushion in these cases. And also have a view of a posterior capsule throughout your surgery and safeguard yourself from a difficult situation coming in these cases. The PPCDD is a sign which is going to make sure that you are in a safe zone. Thank you for kind listening, and I appreciate the invitation from our cities. You're doing a wonderful work.
Thank you. Thank you so much. You so beautifully told us all the points. I don't know whether we have any other question for you. I wonder.
Mohan always will have a question.
Because it's always that, I mean, at every stage, I think posterior polar is always a challenge, and you always are in a dilemma whether you're going to have a tear or not, or what it is. So I think we are always very cautious in these cases.
I just want to make one point, sir. I prefer to do femto catalyst for all these patients, even the patients cannot afford to pay, because definitely the control is better. Intraoperative OCT, which is there, it gives us a very clear definition of the posterior capsule. We can have an offset. I'm sure last time also we discussed during the conference as well. Yes. Very good.
Yeah, absolutely correct, Mohan. The femtosecond does give a better customization of entire procedure. In fact, we have a lot of publication in that also. Nowadays, I do femtosecond, then get the patient to my IOCT microscope again and do the completion there also. So both ways, and femto again with the OCT there, it also gives you the same picture. Though the quality may not be as good as microscope, but you can, in the femto also, you can see the entire pole.
Yeah.
Thank you. Thank you so much. Thank you. Thank you for being here.
Thank you, sir.
I think we'll move on to our next speaker, Dr. Sujata Mohan. And Dr. Sujata is from the Rajan Eye Care again, and a prolific surgeon and a great friend. So she's going to be talking on management of snow white cataracts. Over to you, Sujata.
Can you see my slide?
That's a new term, snow white.
Yeah.
Can you see my slide?
No, we can see you only. No slides.
Yeah, just you.
Share screen, I'm not done. 1 minute. Yeah, I'm sorry.
Share screen.
Yeah. Can only see Mohan, sir.
I think Mohan has taken all the screen share today.
I'm in the hospital and she's at home.
Oh.
Social distancing.
Your services are not there today. That's why she's having problem.
No, sir. I never take the services. You can see it now.
Yeah, yes, yes.
Yes, we can.
Yeah, thank you. So at the outset, I'd like to thank Dr. Reena Sethi and the team Pan Ophthalmologica for giving me this opportunity. The talk is on snow white cataracts. I know it's not going to be as simple as dealing with a regular snow white. So what are the problems in snow white cataract? They have diffuse flocculent cortex. The flocculent cortex may be associated with the hard brown nucleus. Some of these nucleus can be a very soft endonucleus as well. And the most important thing is they have a convex anterior capsule, which results in an intumescent cataract. The increased intraclenticular pressure can cause the famous Argentina flag sign. And some of these also can have a calcified anterior capsule. And most importantly, there is no red glow. So that can actually hamper our surgery. So there's small tips or taking care of managing these mature cataracts are using a pre-op mannitol for these patients. I like to give pre-op mannitol or Diamox prior to surgery, 1 hour before surgery. Using parabulbar injection because these patients are seldom able to focus. It's important that they have good dilatation, otherwise you use iris hooks, and most importantly, stain the capsule. So staining the capsule is, again, I'd like to emphasize one of the most important steps in dealing with mature cataract. Deepen the anterior chamber, use the high density cohesive viscoelastic. And to reduce the lenticular pressure, you can use different methods. You can use a 30 gauge needle to aspirate, or you can use advances such as Zepto or Femto. And most importantly, the new developed technique called the punchorexis. So this is the, you can see as soon as you start the surgery, the capsule has started extending. And this is the famous Argentina flag sign. Though I'm trying to retrieve the rexus, it's not getting retrieved and it's continuing to run away. And the problem with this is when so much of intralenticular pressure is there, it can go all around and cause a PCR. And once you put the phaco probe inside, actually there can be a nucleus drop. So this becomes a major problem. So, but here I would normally advise in these situations to convert into an SICS, manual and SICS, and not do a phaco, particularly for inexperienced surgeons. But in this case, you can see this is quite an old video. It's about 15 years back. And I'm still continuing with the phaco, which is actually quite dangerous because you can see that the rexus are almost extended up to the periphery. And the cataract is not so soft as it looks. It's quite hard, at least about grade 2 to 3. And the one technique I just wanted to show you this is when you do the separation, when you do the chopping, you try to don't go along the axis of the tear. You can do it perpendicular to the tear because you don't put any stress on the zonules at that point of time. And you continue to use the same area for doing the chopping that is perpendicular to the tear so that it does not extend. And after you have made it into smaller bits, you can bring it to the anterior chamber and do more of an anterior chamber phaco and take adequate precautions to protect the endothelium and continue with the phaco, and you can finish the case and implant a lens inside. Most probably in this case, I'd prefer to implant a multi-piece intraocular lens than a single-piece lens. So coming to another case is already stained, you can see, and I'm trying to do the rexus, and the rexus is again running away. So in this case, the technique here is to do what's called as a centripetal rexus. Keep pulling the rexus towards the center. So this is one way of saving the rexus from running away, particularly in cases where there's not so much of intralenticular pressure that you get an Argentinian flag sign, but still enough to cause a trouble. So keep a watch, keep putting high density viscoelastic, cohesive viscoelastic, and keep pulling the rexus towards the center to prevent the rexus from running away. So the next thing which I normally do is use a 30 gauge needle to aspirate the cortex. You can see I'm just introducing the 30 gauge needle after injecting a cohesive viscoelastic and aspirating the cortex so that now the central areas become a little bit more concave. And I'm continuing with the rexus using the edge, and I'm trying to stick to the area where the capsule is concave rather than the convex area, because then again there's a tendency for the capsule to run away. and the rexus is completed very effectively, and you can go ahead with the cataract surgery as you would do for any other case. This is again a case where you can see a cortical cataract with a lot of clefts. Capsular staining is done, and I'm using again a 30 gauge needle in this case. Normally I prefer to use the needle face down, but in this case I'm using it up, the bevel is up, and I'm aspirating as much of cortex as possible. And you can see there's quite a lot of cortex which has been aspirated, and the cataract has become more soft and more manageable, the rexus, and very easily there is no extension, and it comes out very nicely. But again, you have to be very careful when you go towards the periphery, because there are areas where the capsule is still convex, and again, and there's a chance of it getting run away. So this is again, I know this is quite a hard cataract, is about grade 3, and go ahead with the phacoemulsification to a central trench. Do not go beyond the area of the capsule. Try to avoid, do everything in the central area, do a vertical chop, and all the chopping techniques can be done in the center, in your visualization within the capsular bag, and make it into small bits and remove it. So this case, if the capsule is small, you can implant the lens, and then you can always extend the rexus. So next case I'm going to show you is about zeptorexis, which is actually a very useful handheld device, which is made of nitinium alloy, and it has got a ring which is collapsible and can be introduced into the anterior chamber through a 2 millimeter incision. The vacuum builds up and uses small energy pulses to create a perfect central capsular rexus, and that's why it's called as a precision pulse capsulotomy. It is quite popular in the US, though I don't think I see much of it here in India. So the next is the punchorexis, which we have been already discussed. You can see here, I'm using a 15-degree needle, and using high phaco power as well as aspiration at the same time. The advantage here is that when you do this and give just one burst of phaco, you're debulking the nucleus and the cortex, as well as creating a small capsular rexus, round capsular rexus. Then you catch the edge of the capsular rexus. I can go ahead with your completion of the rexus. So the advantage here is that simultaneously it debulks as well as gives you an edge for creating a rexus. So here again, you can see on the right side, the bevel down phaco needle, and one burst of phaco, which will give you a good rexus, a small rexus, as well as debulking the intralenticular contents, so that you can go ahead with your phacoemulsification. You can see that happening, and now you can catch hold of the rexus margin and complete the rexus very effectively without any issues. So the last one I'm going to show you is a femtorexis, which is quite popular. And the only a small tip in this case is just you have to be very careful while removing the capsule, because there might be some tags, areas where it is not removed, not completely cut. So it's important to do something like a rexus while removing the anterior capsule. So a small pupil mature cataracts, you can use different techniques. You can use Malugan's ring, or you can use Bhattacharya ring, or you can use Hydrus hooks and proceed in the same way. Again, in this case, you can see it's an intumescent cataract, so it's double trouble. Small pupil as well as an intumescent cataract. So you can go ahead with one of these techniques. Staining the capsule again is very important in these patients. So to cut a long story short, important pearls are, again, like to repeat, is pre-op mannitol, parabulbar anesthesia, staining the capsule, deep anterior chamber, which is very important, use high density cohesive viscoelastic, release intralenticular pressure during using different methods. Advances such as Zepto and Femto are very useful in these cases. And lastly, what we practice in our hospital is predominantly punchorexis. thank you. And once again, I'd like to thank Reena for the wonderful opportunity.
Thank you, Sujata. Thank you so very much. A really nice talk on white cataracts and snow white cataracts. Thank you. So I think we'll move on to our last presenter of the evening is Dr. Harshul Tak, and he's going to be talking about the Meliogin ring and its magic. Over to you, Harshul.
Thank you so much, Dr. Reena. At the outset, I'd like to thank Dr. Arun Sethi, Dr. Reena, Dr. Aditya, and Dr. Saiban, and the entire team for giving this wonderful opportunity. It's great to be a part of this session. So I'll be speaking on one of the pupil expander device, which we all have been using for more than a decade now. That's the Meliogin ring. So thanks to the inventor of this magical device, that nowadays our life has become much more easier. Can you see my screen, Dr. Reena?
Yes, yes, yes.
Okay.
Yes,
so yes. So nowadays we have many devices which are available in market, like BX ring, Meliogin ring, and OSS pupil expander, greater expander. So there are a lot of devices which are available to use in cases of the small pupil. So I'll be speaking on this particular device, Meliogin ring, today. So this device, we all know, it comes with this injector, and it's made of polypropylene. So this is the previous version of the Meliogin ring, which used to insert it through 2.2 or 2.4 millimeter incision. So basically this ring has 4 scrolls. So all these scrolls, we need to engage the pupillary margin. So this is the leading scroll which goes and catches the pupillary margin, and with the help of the Tugulens hook or Leicester hook from the side port, we can guide these lateral scrolls to engage the pupillary margin at the same time. And once you have 3 scrolls in place, you can take off the proximal scroll and push it to engage the pupillary margin. So once this ring is in place, you can see that pupil is circular, and normally routinely we use 6.25 millimeter of this Meliogin ring, but there's 7 millimeter size also which is available. So once this expander is in place, the pupil, it maintains its opening, and there are no chances that it will come down. And it's very useful in cases of IFIS also. So once you complete the cortical cleanup and nucleus emulsification, you can put the IOL. So to take out this ring, there are 2 ways. You need to disengage all the 4 scrolls, of course, from the pupillary margin one by one. And once you have disengaged all the 4 scrolls, either you can use the same injector which is there, or you can just use a Tugulens hook, invert this, and pull from one of the scrolls, and this ring comes out. So sometimes the 2 scrolls you are able to engage. So you need to put OVD again in anterior chamber and go from side port and engage this scroll. So basically this ring is very flexible, and it's a very like tissue friendly ring. So you can easily engage the pupillary margin. So if the dialer, it gets stuck like this, you need to take second instrument from main port and just disengage this by tacking on this device. And again, you put OVD in anterior chamber and go from side port with the Tugulens hook and engage the 4th scroll. There's another way you can implant this ring, either through, you can implant through injector, or there's another way you can implant this ring is through this cartridge. This is the butterfly cartridge of the micro lens. It goes through 2 millimeter incision. So you just load this ring. If you are reusing this ring, push it in the cartridge in this nozzle, and just load it like we load the IOL. So you again see very smoothly it goes, and the leading scroll engages the pupillary margin. Lateral scrolls nicely, they come out from the nozzle, and they can catch the pupillary margin nicely. And then the proximal scroll, you can easily engage using the Tugulens hook. This was the original version of the Malignant ring. Then came the 2.0 version of Malignant ring. This is a pediatric cataract. Again, the Malignant ring is put. Cortical matter was taken off. This case was a juvenile like metoid arthritis with uveitis. So another advantage of these pupillary expanded devices is that you can make a capsulorhexis of adequate size, which is required for the lenses which we implant in today's time, like the multifocal IOLs, toric IOLs, and all the aspheric IOLs. We need to have proper sizing of the capsulorhexis, which we can only make when we have these implant expanding the pupils, where we can see, like in this case, I enlarged the capsulorhexis for the third time. After putting IOL, I realized that the rhexis is smaller. So once you have these expanded devices, then only you can, so this is another way you can take out this ring. You take off all these scrolls, and this is the injector. So there's a finger-like hook. So you just engage one of these scrolls here and guide lateral scrolls with the equivalence hook to go in this tube, and you can take out this device. So this is the, sorry. Let me show you, this is the 2.0 version of the Malignant ring. Let me take yes. So this is the case which had IFIS. Patient was on tamsulosin, pupil was mid-dilated. So it's a protocol now to use the expanded devices in all the cases which are on tamsulosin and whose pupil is mid-dilated. So right in the beginning, we implant we put the pupillary expanded device. So this is the Malignant ring 2.0 version, which is there now, which has a thinner profile made of 50 polypropylene. It has a stronger material, and the width of the scroll is more than the original version. So it makes it much more easier to engage the pupillary margin, and it goes through 2 mm incision. So see, this has a thinner profile, so it engages pupillary margin much more easier than the original version. So once this ring is in place, you can see there's a black cataract along with IFIS, so it makes our life much more easier. So once you take off everything, put the IOL. Now, once I take off this ring, you'll realize once I start doing, the take off the OVD with this irrigation aspiration, you see the iris is starting to come in the incision. So there's one last video which I want to show, just share. Okay. So this was another case which
Harshul, Dr. Harshul.
Yes, ma'am. Yeah.
Can we just, we're actually running late for the next session also.
Okay, fine, fine. I'll stop here. Yeah.
Fine, just conclude, please.
Very good. Thank you so much for giving this wonderful opportunity.
Thank you.
Dr.
Thank
Meena.
you.
Yeah.
Thank you so much. And thank you all the participants for a lovely session. Thanks a lot. Thank you.
Thank
you. We end the session.
Thank you, Reena.
Thank you. And I'll hand it over to Dr. Saiba, who will be taking the next session over.
Good evening, everyone, and welcome to the Cataract Precision and Perfections session, sponsored by Sun Pharma Vesta session. I'd like to first introduce our illustrious panelists. We have our very own Dr. Reena Sethi, Dr. Lisa Arbizer, who's Adjunct Associate Professor, Moran Eye Center, Utah, and Dr. Arun Gulani, who's the Chief Surgeon at Gulani Vision Center, Jacksonville, Florida. So we couldn't have had a better illustrious team of members on the panel who are so precise about their cataract surgeries. So I'll introduce, as I go along, introducing the speakers. We have first on board Dr. Shelva Savra, who's the Senior Operating Surgeon at Raghudeep Eye Hospital, Ahmedabad. He'll be talking to us about premium IOLs and capsular compromise. Over to you, Shelv.
Very good evening, and thank you very much, Dr. Saiba and Dr. Aditya, for this kind invitation. I'll be sharing some of the complications in planned premium IOL. So this was a patient who was planned for a toric IOL, a 53-year-old male, the left eye cataract surgery already done in 2016-17. He presents to us with a moderate cataract and was planned for his second eye femto cataract with a toric IOL. Doing, like we know, that doing a good capsulorhexis with a good capsulorhexis cover is something which is very important in a case of toric IOL. This was his planned access. So everything started off very smoothly. Good incision, good centered capsulorhexis and lens fragmentation was done. And we like to sort of do things fairly slowly, so a moderate, very low flow rate, and trying to work as much as possible in the center of the eye so that the fluidics are maintained. And if you maintain the fluidics, it's amazing to see that the even the potential IFIS cases, they behave quite timidly if all of these parameters are kept in mind and the probe is kept right in the center. So let things happen in the center of the eye rather than chasing it. And everything has gone off well. Now we have a nice centered capsulorhexis for a toric IOL implantation. Notice here, you'll notice that the plunger is actually overriding on the optic. So this should generally never happen. So your plunger of the injector should be here, somewhere here at the IOL optic haptic junction. And therefore, I'm finding a little bit of difficulty in pushing this IOL. But I thought I've done this few times before, and I'll be careful that there is no jerk in the final injection. And oops, something that I never wanted to happen, a sudden jerky let off of the IOL. And notice due to that, it has gone on and hit the posterior capsule and led to a posterior capsule rupture. Now, this is a very difficult situation in the back toric IOL and a posterior capsule which has ruptured right here and it's extending up to the equator. So since rest of the procedure is done, it's now very, very challenging as to what to do. The options, the simplest or the most logical option would be to explant this single piece IOL and most likely the vitreous will be disturbed by the time I explant the lens, and then exchange it with 3-piece IOL in the sulcus. But that would mean compromising on the astigmatism correction as well. So having had some experience with conventional optic capture, we thought maybe this is a time to consider something reverse from the conventional optic capture that we do. So we decided to attempt a reverse optic capture for this patient. So what we are trying to achieve here is that the haptics still remain in the capsular bag, but we are popping up or popping out the optic above the anterior capsule. And I'm also trying to align it to its appropriate 168-degree axis. So because once it's captured, then it's impossible to rotate it. So before it gets finally captured, I'm making sure that the toric marks are well. And ultimately, after a fairly significant amount of reverse optic capture, this dumbbell is generally suggestive of a capture. So the optic is above the anterior capsule and the haptics are in the bag, and the posterior capsule tear has been left undisturbed. Always confirm for the presence of vitreous or disturbance of vitreous by injecting triamcinolone. Unfortunately, there was no vitreous disturbance that had occurred either due to the tear that occurred due to injection or during the reverse capture. And even while hydrating, make sure that the chamber is formed. So do not withdraw your irrigation until all the rest of the ports are hydrated. And fortunately, we could center the toric IOL, at least on table, we felt it was doing quite okay. We have now a good follow-up of this patient. Now having completed more than 3 months post-operatively, he ended up with a little bit of myopia, but fortunately the IOL is very stable and no, significant uveitis or anything to be worried about. So reverse optic capture is a viable option in certain special situations. Of course, these patients have to be chosen very carefully because you need a good size anterior capsulorhexis, because if the anterior capsulorhexis is very large, capture cannot be achieved and then this entire strategy has to be given away. And of course, these patients will have some more inflammation and more IOP in the post-operative period because viscoelastic will be trapped behind the IOL. So in such situations, we like to give mannitol to these patients post-operatively and IOP lowering and more aggressive anti-inflammatory for about at least 2 months post-operatively with non-steroidal anti-inflammatory eye drops. This is another patient, a 30-year-old male, bilateral posterior polar cataracts, and like was discussed beautifully in the previous session, we tend to prefer to use the femto cataract platform, and we like to do the cylindrical lens division patterns because most of these patients, particularly the young ones, the cataract is very soft, so we can remove them layer by layer without doing any form of hydro procedure, something what we described as femto delineation. So we are just aspirating one epinuclear plate from the support of the other, so that there is no hydraulic maneuvers or lot of no form of rotation or anything that is required. We scoop it out like ice cream from a cone to make sure that there is no rotation that is required. When we come to the final epinuclear plate, our aim is not to remove this final epinuclear plate completely. So what we'll try and do is we'll just try and detach it from the fornices. So this will make sure that some fluid now starts trickling behind. So now there's a communication between the anterior and the posterior compartment. And now at this point of time, if you come out and even if you do hydrodissection, it is very unlikely to rupture the capsule because now there will be no rapid buildup of intralenticular pressure. So this is what we started off with. And irrigation aspiration will be a little bit more challenging because there is a relatively thick epinucleus that is left behind. We prefer bimanual irrigation aspiration, particularly in cases with posterior polar, because we don't want the chamber to collapse at any point of time. And finally, fortunately, we were able to remove everything, and luckily the capsule was completely intact. And this patient was planned for a multifocal toric IOL if everything went as per plan A, which it went. Now, sometimes you get ahead of yourself, and I got ahead of myself here, and I thought, let me polish this little small plaque. I'll be able to pick it up with vacuum, which is something that should never be done. And notice from an absolutely uneventful case, I've converted into an eventful case. So at this point of time, now having done this, do not panic. Do not withdraw your instruments. So the first thing I do is to inject a dispersive viscoelastic, which will tamponade that area. And now I decided, having some experience with posterior capsulorhexis in pediatric eyes, to try and convert these weak edges of the posterior capsule rupture into strong margins. Because if we can convert it into a strong margins, we still have hope of salvaging this case. So we went ahead and we have to convert it from both sides. So just converting it from one end alone will not be sufficient. And as you can notice, this patient was under topical anesthesia. So that was even a little bit more challenging, that we don't catch any strand of vitreous while converting this capsulorhexis. And having done it from one end, now we need to go and do it from the other end, because unless it is converted from both sides, even if you do it only from one side while injecting the IOL, this can still split and lead to an extension. So we have been able to convert this into a strong capsulorhexis now. And if you have a strong capsulorhexis margin, this will act like an anterior capsulorhexis. So now we can consider using this capsular support for an in-the-bag IOL implantation. And remember, this was a multifocal toric IOL. So not only was centration important, but alignment of the axis was also important. And the main concern with an open capsule would be, first of all, stability of the IOL, if any tilt or vitreous disturbance is going to occur or not, and rotational stability, because if it doesn't remain rotationally stable, then again, the entire point of attempting this goes in vain. So at least on table, things seem to be going off well, and we were able to align the IOL to the appropriate direction. And this is how we ended up on the table with a good anterior capsulorhexis, a good posterior capsulorhexis, and an aligned IOL. And this is the patient now, almost more than 6 months follow-up. The IOL has not rotated even more than a couple of degrees. That would be normal. And the IOL is very well centered with no tilt and no other issues. So toric IOLs can be considered even in select cases of posterior capsular rupture, if you are able to convert it into a strong posterior capsulorhexis margin. And stability is not an issue in the long term. But the most important lesson from this case was never ever try to attempt to touch the posterior capsule of a posterior polar cataract. Thank you so much for the patient listening.
Thank you so much, Shell. That was very, very interesting. And I really hope that you can stay on till the end of the session, because this is going to create a lot of interesting discussion at the end. So next, I will, without much ado, call Dr. Reena Sethi to deliver her talk on toric IOLs in my practice, aligning with my patient expectations.
Thank you, Dr. Saiba. Can you see my presentation? Can you see my?
Yes.
That's here now? Yeah. Okay.
Yeah.
So I'm going to be talking on refractive cataract surgery in patients with astigmatism and toric IOLs in my practice. So really, I mean, when we are counseling a patient for a cataract and the IOL, and we talk about monofocal IOLs, then exactly what are we talking about? And the patient has astigmatism. So we have to tell the patient why we are using these, are intending to use these toric IOLs, because that's the quality of vision that a toric IOL after the astigmatic correction would give the patient. And what has happened and why are we doing these toric IOLs? My attitude towards cataract surgery has changed ever since I started thinking about astigmatism also when I'm dealing with a cataract patient. Every patient may be a candidate for astigmatic reduction, astigmatism reduction. And our aim here is a quality of post-op uncorrected vision. We need to give our patients the best quality of vision. And if our patients have cylindrical corrections also after the surgery, then really they are not getting the best vision that they need to have. The goal is reduce dependency on glasses. And I've come to become a refractive cataract surgeon when I'm actually thinking of the astigmatism also. So even before I do vision, I now check for astigmatism. So in every patient who comes to me for a cataract surgery, I check whether the patient needs an astigmatic correction or not. So that is what has changed in my practice. So this is a study in which there are 6,000 cataract patients were studied, and they've seen that more than 50% have a requirement for correctable astigmatic toric IOL correction. So that's how high is the incidence and the prevalence that we need to put in toric IOLs. And who are these patients in which we should be putting the toric IOLs? These are the ones that have greater than or equal to 0.75 diopters of astigmatism. We need to have a special focus on against the rule astigmatism. So a patient who's been left post-operatively against the rule astigmatism would never be a happy patient. He'll always be having a problem. So present pre-op regular astigmatism also needs to be corrected. And so no pre-existing ocular pathology should be there in these patients, no previous refractive surgery, or even if there has been, the astigmatism has to be regular in the pupillary area, no previous corneal surgery, and intact capsular bag. And desire an improved distance vision with lesser dependency on glasses. So that has to be our aim, that we need to have the patients lesser and lesser dependent on the glasses and the glass spectacle free, at least for distance vision. And this is the corneal topography, which is the key. And we need to do this in all our patients to assess that, whether they need a toric correction or a correction of the astigmatism or not. Do they have a regular symmetrical astigmatism? Is it with the rule, against the rule? Who are the good candidates? And when not to do the toric IOL, whenever there is an irregular astigmatism, because we will not be correcting any which way the astigmatism that is required, especially in the pupillary area. That's what we need to see. Or an asymmetric astigmatism also. Talk to the patient. We have to explain about astigmatism by simple day-to-day examples. And one thing which works is, if you have the attendant who's there with the patient and you're counseling your patient, try and put a cylindrical number in front of the patient, the attendant's eye, and then he would tell you that no, the vision is unclear. So that's what the patient's vision would be if you do not put the toric IOL. Has to be explained to the attendants as well. So discuss spectacle independence, especially depending on their work profile, and balance their expectations. Still, you don't have to give them very high expectations of their results. And you need to still tell them that they need readers after that. So make a recommendation and don't force your opinion. So this is the kind of pre-op that workup that you need to do. You need to be very careful, and especially a word about the ocular surface is very important. If you see that your patients have dry eye or have a meibomian gland disease, treat them first, and then only let them wait again, and then repeat their biometry with different techniques. The optical biometer would be more effective, and then come to the conclusion which exactly IOL did you want to do. So in your worksheet, you must always have both the eyes, which have to be calculated. This always helps in the counseling, because one eye may require the toric IOL, the other may not. So you need to counsel the patient for both the requirement of both the eyes, and reduce the refractive surprise. So you need to go in for a negative, with the rule, minimum with the rule astigmatism. The important pearls here is that you need to mark the eye. A toric bubble marker helps. You could also mark on the slit lamp, and always recheck with the other method. So in my practice, I try and do all three methods. I do the bubble marker, then I check on the slit lamp, and with the toric arm, I reiterate that whether the axis has been right or not, and if there has been a shift, what exactly is the intended axis I have to be making my incision. And then the intraoperative marking is also very important. So this is to be marked intraoperatively before you start the surgery. So after this, during the toric IOL implantation, it is very important that you leave the IOL at the intended axis, and be sure that you do that and the IOL is stable, and especially after you've taken out the viscoelastic. So wash and alignment and hydro is an important step. Washing and hydroing, so that you can easily, while you're doing the aspiration, you need to just see that you have aligned the IOL at the intended area. And then with the irrigation cannula in, once you've taken out viscoelastic, you can leave the IOL at the axis which is required. And then with the hydro still in, you need to hydrate your wounds so that the IOL. So there could be certain areas of potential source of error. It could be the biometry or the marking, cyclorotation, could be a capsular fibrosis. So it's important to analyze what went wrong. And then once you do that through your analysis, in certain cases, you need to redial your lens also if you have a refractive surprise, so that these patients should always be, you have to tell them this is a cylindrical number or a cylinder that has been implanted in the eye. So you may require a little bit of tweaking sometimes. So this is a case in which, the patient has come back after a month. So we see a bit of tissue there between the anterior capsular rim as well as the IOL, which is with a viscoelastic. It is very easily teased out, and gently the lens is also rotated, nudged. And if we see, once we see that all this tissue has been removed and the lens is easy to nudge, then we slowly, gently, we need to rotate it and get it back to the intended axis. So the take-home message is that toric IOL is an excellent option for cataract patients with significant regular symmetrical astigmatism, and a proper preoperative workup is the key. Intraoperative care to be taken when finally aligning the IOL along the intended axis. Thank you very much.
Thank you so much, Dr. Reena, for keeping time also. So what you pointed out was very important. I think toric IOLs have really revolutionized our practice completely. And I know that for us, every third patient is a toric, receives a toric IOL, and it's amazing how we can keep them spectacle-free. So a little more about that at the end of the session. Next, I would like to call upon Dr. Lisa Abizer. She's got 2 talks, which I'd request her to give back to back. The first one being the many phases of capsule capture. The second one being seesaw hydrodissection. Over to you, ma'am.
Hello, can you see my screen?
Yes, ma'am.
Hello. And you hear me. Very good. Well, thank you so much for the invitation to join. I've had a long association with your family, starting, of course, with your parents, and it's been an ongoing pleasure for both myself and my husband, who's a pediatric ophthalmologist. So it's a pleasure to join you. I want to talk about the many faces of optic capture, and it's critical that that's the first thing we think of when we have a complication. How can we place a lens securely? And one thing about optic capture is that it's essentially always secure. I have no financial disclosure regarding this. Well, of course, optic capture is not my idea. Howard Gimbel, the giant in ophthalmology, first described it and published 6 types of optic capture as early as 2004. And the idea being that whenever the IOL optic and the haptics are on opposite sides of the tear-resistant opening in the capsular membrane, then we have optic capture. So it can be in Berger's space through the posterior capsular rhexis or capsulotomy. It can be reverse, as we saw earlier in some of the talks, with the optic in the bag, and we'll go through each of these, or the standard type, which is placing a lens in the sulcus, a 3-piece lens, and then optic capturing down into the bag. And we can also use diffused fibrotic capsular membrane for this in situations that are secondary or with trauma. So the standard, of course, is a 3-piece lens being placed into the sulcus. And we always want to measure our capsular rhexis as we begin to make it in the beginning, because this is our most critical backdoor safety. And here you are just pushing on the 2 poles 90 degrees apart after placing the haptics in the sulcus. Push on the 2 poles to push the optic down into the bag. And I think people are very familiar with that form. You know, there's actually, people think of bag lenses and sulcus lenses. At least in the United States, there is no FDA approved sulcus lens. And we no longer have the Star AQ series, which had 14 millimeter haptics, haptic to haptic, and excellent memory with the elastomide. But rather, the 3-piece lenses that we have today are only 13.5 millimeters with very poor memory and very elastic or fragile, essentially, haptics. And they really will not keep a lens reliably centered in the sulcus without movement, or in the case of complicated situations, finding its way into a tear or an opening in the zonule. So I think it's really very important to go ahead and plan to optic capture, or sometimes suture to the iris, or make sure we have some other way to secure it. So here I'm checking my posterior optic capture, and before I'll make a primary posterior capsulotomy, which I'm doing in this particular case with a 30 gauge bevel up needle, after placing cohesive viscoelastic into the sulcus to combine the anterior and posterior capsules together into one membrane. We've made an opening in the capsule that's 4 microns thick, and now we're irrigating cohesive OVD into Berger's space, which is the space above the anterior hyaloid and below the posterior capsule, delimited by Weigert's ligament, 360 degrees. And now we can use a slightly more centripetal movement, because this is very elastic, a 4 micron membrane, thick membrane that's very elastic, kind of like a pediatric capsular rhexis. And so we're going to pull a little more centripetally and regrasp a little more often. And because we have things under very fine control, we virtually never experience any posterior pressure with our OVD in place, pushing the hyaloid back. And we can easily, really quite easily complete a posterior capsular rhexis, just a little smaller than the anterior rhexis, which we're using as a cookie cutter template. Now we're putting our OVD into that spare tire that we've created with the posterior rhexis below and the anterior rhexis above. That's going into the capsular fornix. I'm going to slightly enlarge the incision because I don't want to have any precipitous entry, so I won't do a wound assist. And I'm using a screw type injector where we're injecting into the bag. And the most important part is just visualizing your leading haptic going above the posterior rhexis and under the anterior rhexis, so that we know that that's in the bag, which allows us to easily rotate the trailing haptic into place. Once we have the lens nicely in the bag, and sometimes we can place that primarily with the pusher, but it is nice just to be absolutely certain that we have that perfectly fixed. Now, just like we did with the anterior rexus, we can push on the pole 90 degrees away from the optic-haptic junction. But you'll see here that I'm being a little more subtle with it because we have to almost walk it from optic-haptic junction to optic-haptic junction to be sure that we get that football-shaped look, that cat-eye appearance. And you'll see after I'm irrigating some of the OVD away from the anterior chamber, keep in mind that we'll never clean OVD from the posterior chamber. This is an early case of mine, so I've added a little tree essence, not necessary once you are through your learning curve. But Dr. Menapachi has shown us that when we remove the anterior capsule viscoelastic, that trapped behind in the capture will not cause a pressure rise, nor is there a higher rate of CME or retinal detachment. So posterior optic capture can be useful as a primary procedure, as I've shown you here. Or, for example, if you break the posterior capsule, you can enlarge it then into a continuous opening and capture. And the main advantage of that, of course, is that we would have virtually a zero incidence of posterior capsule opacity in a perfectly clear space. Now here's a toric lens like Rena showed us that rotated, and actually interestingly this lens rotated once. We do like to look wait 2 weeks before putting it into the proper place to allow the bag to kind of phimose a little bit and maybe not be so big to allow rotation. In this particular case, this patient had already been re-rotated once 2 weeks post-op and rotated again. It was quite a myopic eye. And although some people have placed a CTR to avoid rotation, I find that's not uniformly valuable. So instead, I put the lens back into the proper place, and now I'm going to forward capture. In other words, reverse optic capture, leaving the haptics in the bag, which is essential. We never want a one-piece lens haptic to be in the sulcus. Leaving the haptics in the bag and cantilevering the edges of the optic up above the capsular rexus, which needs to always, if possible, be 5 millimeters or so when you make it for this. So you have this opportunity. Of course, any captured lens will never again rotate. And interestingly, we decided in this patient's second myopic eye, knowing that this had rotated twice, to place that CTR the initial time. And she rotated anyway, despite the CTR in the second eye. That's an aside, but I wanted to show you the opportunity to forward capture or reverse optic capture. And now that Mastel is showing us that the reflex off the lens and off the cornea are 90 degrees apart, as we'd hoped. Now, Gimbel most recently published something that he calls haptic tuck, which is the same ultimate outcome as reverse optic capture, but it's important technique because if, for example, you saw earlier in your seminar, someone have a lens already in the bag, but then have a break in the posterior capsule or then see one, then you can insinuate, as I showed you, the optic forward, leaving the haptics in the bag. But here's a case where we had a break in the posterior capsule prior to implantation of the one-piece lens. And rather than just go to a three-piece lens, there is the opportunity to haptic tuck, meaning we place that one-piece lens in the sulcus and then tuck the haptics down into the bag so that it remains in the same ultimate position where the optic is captured forward of the bag, but the haptics are in the bag, allowing us then to less manipulation as you rather than trying to place it in the bag and then forward capture. Now, here is forward capture from Burger Space, and fairly early on in my learning curve of doing fairly routine posterior optic capture, or at least in appropriate situations, I tried using a different lens than I had used before, in that the more the optic haptic junction is a 90-degree angle, the less likely you will ever have at any age any posterior optic intrusion of cells after posterior optic capture. And this was a much stiffer lens than I expected, and I had made an awfully small posterior capsular rexus, although it's quite forgiving because it's so elastic. In this case, I'm seeing that I'm having difficulty walking that along, and I've gotten the first pole in, but in trying to get the proximal edge of the lens in, I see that excuse me? Oh,
Sorry
I
to
didn't know you.
over.
Oh, continue. So anyway, and see, what I saw was that I had ruptured the posterior capsular rhexis, and therefore I'm now forward capturing from Berger space into the anterior chamber, leaving the haptics in the bag. Another variation, and this patient did extremely well, though here I would use triessence or triamcinolone acetonide. Triessence is the on label in the US. I have no financial interest to be sure that there was no vitreous prolapse. Since I did rupture that posterior capsular rhexis, we did find that anterior capture from Berger space to the anterior chamber worked well, and a little puff of triessence will demonstrate that there is no vitreous present, no vitreous herniated forward, and the patient will do extremely well. Sometimes when forward capturing a one-piece lens, one can get retropulsion of the iris in an at-risk eye, and so one should always follow those patients closely to be sure that you don't get an UG syndrome and might need a PI. And I add that as a little addendum just to be sure to watch. This is a traumatic cataract that had a fibrotic opening in the posterior capsule and also had some zonulolysis, so that I did not want to depend on putting the lens in the sulcus, and instead or leaving the lens alone in the sulcus. So instead, I placed the lens in the sulcus, and now I'm actually going to capture through the fibrotic membrane. Because this was a traumatic cataract of fairly long standing with this opening, well, we had to go in because of uveitis. Nevertheless, it was there long enough to create some fibrosis of the posterior capsule, which can be very sturdy. And then, as you see here, I've managed to actually capture that lens through that fibrotic opening in the posterior capsule. So it's another form of optic capture. And then we can go about fixing the iridodialysis and the permanently dilated atrophic pupil with sutures. So I won't continue that. Another option, which is something that I've described, although it was originally described by Dubroff only with anterior vitrectomy in the pediatric situation, is to double capture. And I'm calling this a hyaloid sparing double capture. Let me turn this off. What that is we're placing, we've done an anterior capsular rhexis and a posterior, primary posterior capsular rhexis. The lens is going into the sulcus, and now will be captured through both the anterior and the posterior rhexis. The advantage of this remains to be seen as far as any really good study. Posterior optic capture that's hyaloid sparing alone has been thoroughly studied in fellow eye prospective randomized trials by Rupert Menapacci and others, Tassignon in particular. And this is kind of a concept that combines the bag and the lens concept that Marie-José Tassignon has, where there's a kind of a collar button into which we insinuate both anterior and posterior capsules, so that we've collapsed the anterior and posterior capsules by optic capturing through both with the haptic in the anterior chamber and in the sulcus, excuse me. And so you can see both the football of the posterior capsular rhexis and the football of the anterior. And this may have some tremendous advantages in the long run, but still remains a subject of study. It's been used quite a few times by Dr. Oding at University of Iowa in both pediatric and uveitic cases and other complex cases with excellent results. So thank you very much for your attention on this. I think I have to stop sharing and see if you have any comments before I reshare for my other talk, which is shorter, so I should be able to stay pretty much in time limit.
I do have a quick question and maybe one comment from Dr. Lisa and Dr. Shell as well, since they both have common interests. So what would be that one absolute contraindication for you to be doing a primary optic capture?
What would be the one contraindication to ever doing a primary posterior optic capture? Is that right? You mean a primary CCC? Well, if we don't have control of the anterior chamber and we have posterior pressure, we certainly can't do that. As long as we can control the anterior chamber, then we can do that. Another possibility would be if we had fibrosis that goes beyond where you would like that posterior rexus to be, then we might have to sacrifice the anterior hyaloid. So that would be a contraindication, although certainly that's a primary goal with vitrector, posterior vitrector rexus in pediatric cases. But my goal in doing this is to spare the anterior hyaloid. So if for any reason I don't think I could do that, then I would not do that in that fashion. I would not attempt a primary posterior capsular rexus if I did not have a capturable anterior rexus. So if we have 2 out of 3 problems, all zonular problems as well as an anterior rexus not working, or even if the anterior rexus isn't capturable, then I would think that the risk might outweigh the benefits of doing a primary posterior capsular rexus. I hope that answers adequately your question.
Noted. Shel, what about your views?
Yeah, I think the most important contraindication would be sizing. If the sizing of if I'm not able to create a large enough posterior capsular rexus for whatever good or bad reasons, it's best to leave it in the bag. I would have just a slight divergent view in terms of the anterior capsular rexus. If particularly in a pediatric case, if I end up with a larger anterior capsular rexus, that is the case where I will definitely want to do a posterior optic capture, because I don't want much of the optic slipping out and coming up to the iris. Particularly in the pediatric eye, they do cause long-term inflammation. But I think sizing of the rexus is the most important part.
I agree with you, although I would simply add that it's just as easy to make a little radial cut in the posterior rexus and dial it around to enlarge a too small rexus as it would be for an anterior rexus. And I have done that. I have video of that. Yes. So we can, if it's too small, we can always enlarge it to being appropriate. If it's too big, of course, we cannot capture unless we have a bigger optic to capture.
So I have a question about the bag in the lens. By Dr. Mary. Do you think that's a good solution as well? That looks quite interesting.
Well, I think there are some major advantages to it. Of course, I have no personal experience. It is not FDA approved, but I have been in the OR with her, watching her. Now, the disadvantage is, for one thing, it is totally zonular dependent. But we are finding that there's virtually no phimosis of the capsule, when we do this, which is the big advantage. I'm even thinking that perhaps bicapsulotomy capture, as I showed you, hyaloid sparing bicapsulotomy capture, which I really have, I think, initially thought of, according to Gimbel, with hyaloid sparing. I think that may solve 2 problems. One is our need for posterior opacity YAG laser. And the second is that it may help us with our pandemic or epidemic, I should say, of bag lens subluxation, because it excludes the possibility of phimosis. With regard to bag in the lens, it's the other challenge of it is that the 2 anterior and posterior rexes have to be perfectly centered and perfectly sized, or else one can't use it. So technically, it's much more challenging, not to mention the fact that we can use any 3-piece lens for a hyaloid sparing bag, a double capture, whereas it has to be that one currently non-FDA approved bag in the lens. But yes, there's also an article in the literature that shows that needing vitrectomy afterwards is really wonderful with a bag in the lens, because you have a perfect clear view, everything stays stable, you don't worry about destroying the posterior capsule, which is already kind of gone. And so it can have some major advantages in future. And she's had wonderful outcomes with it, but there are a few people who are able to use that as their primary technique because of the technical challenge.
Thank you.
Great. Thank you, ma'am. Thank you, Dr. Shel. Ma'am, you can share your second presentation if you're ready with that.
This should be quite short. The thing about it is I have not formally described it, but I'd like to if anybody wants to publish with me. And it's something that I realized very early on. Once again, I have no financial disclosure. And what this has to do with, we all know that hydrodissection involves placing a cannula underneath the capsule. And of course, Fine described cortical cleaving hydrodissection, which I'm not a huge fan of, in that it tends to leave little little wisps that are hard to gain vacuum with, at least in a peristaltic machine, and remove cleanly. At any rate, what our plan is to irrigate under the anterior capsule and to release the lens from its attachments to the bag for safe removal. And people describe it as a simple technique of injecting fluid. In rare occasion, we can have a capsule blowout, because if we have a very big dense lens and we're just slightly aggressive with that, then it may not be able to escape on the other side, and we can actually blow out the posterior capsule, which can lead to really crummy complications, since it can be hard to even diagnose until you put your phaco tip in and everything goes south with the irrigation. So I have always thought of hydrodissection a little differently. Another thing that can happen is, especially in an IFUS case, when you irrigate hard into the capsule, is that you may blow iris out because you've increased the pressure, and you may not be able to release that through the main incision. So I think of irrigation as while irrigating, as a subtle ballottement downward as you're irrigating, to make sure that the capsule and the lens allow fluid to come out to be burped. And then by the same token, seesawing the other direction ever so slightly to burp the incision, so that we don't gain a huge amount of pressure anywhere, and we can still get that nice travel of the fluid wave that releases our lens. I do like the McCool flat thing, and it's hard to see, and I haven't had video to be able to show you from the side, but I think descriptively you can understand that I go in and then I'm down as I'm irrigating, and I'm seesawing ever so subtly as I'm irrigating. So that's what I wanted to just put in your mind as a subtlety of how you might be able to avoid. And I personally never in my entire life had a blowout of the capsule. I have virtually never in 30 years had a transillumination defect from iris prolapse. There are many other techniques to avoid iris prolapse, but this is one of them, certainly in an IFUS case, just never causing the pressure to be such that what's going to give is the iris of that incision. So I hope that's clear, and it's a subtlety that you can keep in your mind and just keep in mind as you're irrigating, that it's a slightly more complicated movement than simple plunging of the syringe.
That's a very interesting concept, ma'am. Although, would you only like to try this with hard cataracts? What is your
especially with hard cataracts, especially when there's a lens, that's where you have the highest incidence of capsule blowout, is a very large, hard nucleus, because there's not a lot of space for everything to go, and not a lot of, big cortical space there so often because of the nucleifying, of all of the material and the growth of those lenses. So because those lenses are big, they tend to fit very tight into the bag. And so that's especially where we want to be thinking about that little subtle movement to push that down as it goes around.
So, ma'am,
try it. You'll like it.
Doing this,
what's that?
What will be the rationale of doing this in soft cataracts versus the traditional hydrodissection?
It's just so minimally different from what you would normally do, but you won't blow out an iris in a soft cataract with an IFUS. If you're thinking about releasing that fluid slightly from the wound by slight pressure on the posterior lip, and it won't interfere with your ability to do what you need to do. Now, of course, the key to a soft cataract is not so much hydrodissection as hydrodelineation, because there's still that nice little plane where you can get that the golden ring, and then easily lift out that nucleus, and then you're kind of all done with a softer cataract that way. This is less necessary. You don't want to really do this kind of thing when you're hydrodelineating. It's when you're hydrodissecting that you take that risk that you're going to get that tamponade of the nucleus and the anterior capsule all around, even though you have that one little thin irrigating cannula in there, you're still pretty well tamponaded, the bigger and denser the lens. And so you prevent that by allowing fluid to leak out as you go with that seesaw maneuver.
That's very interesting, and I really feel that it's very brilliant to come out with really subtle alternatives. You know, something which is just so simple. Innovations which are simple are the best. So this is
Thank
a very
you. Well, if you want to submit this to JCRS with me, let's write it up. Okay. Get some good video on the side. That would be lovely.
Michelle can be on board as well.
Okay.
So I'd like to now
glorious.
Yeah.
Sorry,
so I'd like
that
to now
would be glorious. Yes. I'll mute.
And she'll be talking to us about benefits and new features of modern international internet database IoT.
Again, thank you very much for having me and for inviting me and for allowing me to tell you my topics. Here should be my screen.
Yes.
Here we go. So as mentioned before, I would like to introduce you shortly to the most modern internet database worldwide available of IOL specifications and constants, and especially of optimized constants. As mentioned before, optical biometry changed cataract surgery fundamentally, and it's only 20 years old. It's not that old. There was and with the optical biometers, the need for optimized constants arose. And the first person who set up an internet database was Professor Heiges from Würzburg. It was called ULIP. Most probably everybody knows ULIP database because it was the only place where to find optimized IOL constants for cataract surgery. ULIP was not really, it set a standard of its time, but for today, it's not modern anymore. And Professor Langenbucher from Homburg, also Germany, wanted to establish a modern database with more IOLs in there, open to all IOL surgeons and companies. And that's what he did with establishing IOLCon in 2017. So as said, ULIP set a milestone of its time. It was really the holy grail for IOL constants at that time. But from today's perspective, it's not modern anymore because it only focused on the size IOL master. The IOL master was the first optical biometer, so it made sense to set it up especially for this device. But today we have many more optical biometers, and we need a database which is open to all the manufacturers of those biometers. ULIP was almost like a static table. It had only very limited filter functions, and it was not really easy to use. Most of all, for all the other biometer manufacturers, it had no open interface for downloading the parameters from the database directly to the biometer, except for the size IOL master. It was the first one, so it made sense. And ULIP has not been updated since 2016 because Professor Heiges went very ill, and almost 2 years ago, he finally passed away very sadly. And so there is no update of ULIP to be expected anymore. So Langenbucher wanted to establish something which is most modern, which is really easy to use with a self-explanatory functionality, really absolute idiot-proof, let's say. And in my opinion, he did so. There is this database available, and I will introduce you to it. So I told you before, it was launched mid of 2017. It offers everything we were dreaming of, and I hope you will agree. Let's have a look at the layout, at the optical layout. You can see here a screenshot of the optical setup. Most of all, I mentioned it before, it's free of charge for you as ophthalmic surgeons. It's an essential tool. You need it to really, and it's accessible from all over the world. It's available in the internet. You have many, many search options. I will show you. And you have also the option to just to print it, just to print a piece of paper. And it looks very easy to understand, very good, get a really good overview over all the options all the specifications of the lens. Back to the optical view, you just see a screenshot how the page will appear to you if you check it out in the internet. You see all the lenses according to the manufacturers in alphabetical order. On the left side, the information which is given or uploaded by the manufacturers. On the right side, you will see the optimized constants which have been optimized by IOLCon. So just a short overview over all, not all, but some of the main selection criteria you can check out for lens manufacturers. You can check out for the material, for the haptic design, for the used biometer, for the ethnic background of the patients, and many, many more. It's really a useful toy. And if you have the time, just take a few minutes and check out what all you can select in this database, and then push the button, search for corresponding lenses, and you get your results. As mentioned before, the screen is divided into two parts. On the left side, the information from the manufacturers. On the right side, you will see the information from IOLCon. And this is meant with, there you can see the optimized constants, which have been optimized by IOLCon. And what is really nice to see is there is a color coding of the quality, referring to the quality of the analytics behind this optimization. Green is far better than yellow and far better than red, like a traffic light system. And also you will see the, which way the toric lenses are uploaded by the manufacturers, either as refractive powers, a sphere, or a spherical equivalent. But you can find all this explanation also in the footnotes of the page. There's even more details can be found if you use the mouse, the cursor of the mouse, and go over the square of the specific optimization. Then a new window will pop up and will show you the data behind this optimization, all the details as you can see on the screen. This is very, very informative, and you can really, it's transparent. It's showing you everything what Professor Langenbucher did to optimize this constant. So the benefits for you, for the ophthalmic surgeons, are you receive, if you register and upload your refractive results, you will receive your personalized, optimized constant completely for free. Global optimized constants are available based on community data, and you see either the link or the QR code how to get to that web page. The only thing is you have to register, you have to put in your name and your details if you want to use this personalized, optimized constants option. And the way is absolutely easy. This is the main page when you arrive at IOLCon, then please hit the button Contact, and the next page will show you the registration platform. Just put in your name, your email address, click on Register as new user. If you want to leave a message, do it, but you don't have to, and then click on Send Form. After your registration has arrived, or your request has arrived at IOLCon, you will be in contact with the colleagues at IOLCon. They will send you your data, your registration data, and then you can log in into the personal with your personal account, and then you have the option it's about how to upload your refractive results, and you have the option either to use an XLS spreadsheet or an XML template, absolutely according to your preferences. It doesn't matter anyway, and you can download it, the sheets from the page as you like. The good news is IOLCon is growing steadily. Here you can see the numbers I just picked from the website. We now have 527 models from 31 manufacturers with more than 23,000 clinical data from 131 IOLs. Even nicer is that the biometer manufacturers integrate the direct download option, the direct interface into their devices, so that you don't have to download it by a USB stick, thumb drive, and put it to the biometer. You just can log in. You just connect your biometer with the internet and download the data from IOLCON's website. For example, the Antirion from Heidelberg Engineering, the OR 2000 by Tomi, did already so, and also the IOL Master 700 with the latest update. They allow this direct download option, which is really, really good for you. You don't have any additional work or to transfer the numbers by yourself. This is very convenient. So in conclusion, this is right now at the moment the only available up-to-date internet database for IOL specification, and most important for IOL optimized constants. It's global, it's interactive, it's always up to date. The good thing is that the manufacturers of the IOLs, they can keep their data updated, and they are interested in doing so. So you can rely on the data which is shown by the manufacturers. They are interested and very helpful in uploading their own data. Whoever of you attended my first lecture, you saw this recommendation as well. There's an article available in the internet or at the German Ophthalmic Surgeon Journal, but it's written in English. And by this article, if you're interested in IOLCON and the details, please go ahead and check out for this article. You will find many, many or much more information about this database. So far, thank you very much for listening to me.
Thank you.
Any questions?
Thank you so much, ma'am. I think this is just yet another tool in our armamentarium, which probably will reduce our burden of refractive surprises, and we can't really have enough tools yet, having said that. But I guess now, since this presentation is going to be available on YouTube, it's a little complicated to understand, but it's recorded out there for anyone who wants to go out there. And if they want to get in touch with you, ma'am, how should they get in touch with you?
You can share my email address. It's absolutely fine for you if you share my email. And I will build a link to IOLCON if you like to. I'm happy to help and to support.
Great.
And also we have a LinkedIn page and a LinkedIn account. And also there you can find some information or can contact IOLCON directly via this option.
Noted. Thank you so much, ma'am. Thank you.
Next
up. Thank you. Next up is Dr. Sethi. He would be talking to us about traumatic pediatric cataracts, retrospective review of cases at a tertiary eye center, and he'll take up the moderation and the podium from here on.
Dr. Lisa had a question for, I think, Dr. Schultz.
Sorry.
Ma'am,
Ma'am, you're muted.
I did. Okay, there we go. My question is, the basis of the personal A constant has to do with the size of capsulorhexis you make and how thorough you are in removing cortex, I assume, because the only thing that's in question is what is the effective lens position, correct? I mean, that's really the only issue. I wonder if you have any real data that shows that it makes a difference. Like, for example, I used to optimize my incision for astigmatism, and sent it to Alpert and, Dr. Alpin, who's, brilliant in Australia. And then it turns out that that we find out that the centroid should really be used by everybody, that whether you came out of 0.4 or 5, really just use the 0.2, for your best calculation. So I wonder if you have studies that really show how much it makes a difference to have your personal, and to make sure that people only use the data of the lens in the back, because if some are captured one way or another, or in a sulcus or whatever, that throws everything off entirely. True?
Yeah, sure. We did not publish such data or such studies so far. The database is quite new, and we're still in the process of publishing the benefits. That was the first peer-reviewed article ever published. I just showed you before. It's a young team. It's a very active team. And if you're interested, let's get in contact and just share your feedback and your expertise with Professor Langenbucher.
I'd be happy to. I don't know what I can contribute. I'm not a mathematician, or a statistician, but I just wonder about how consistent it is, for coming out with better outcomes. Thank you.
I cannot share the data right now with you because it's not yet published. But if you're interested anyway, get in contact with him. He would be really happy to discuss that with you.
Thank you. Perhaps I'll get his email from somewhere. Yes, thank you so much.
You're welcome.
So thank you for that very amazing talk, ma'am. I'm going to talk about traumatic pediatric cataracts. I thought since we spoke about pediatric cataracts earlier and traumatic cataracts also, a little bit of retrospective review we did at Arunodaya. So no financial interest. The purpose of the study was because traumatic cataracts are a war, and especially when it comes to children, this war has consequences which will last for 80 more years. So we have to be targeting our approach, and we'll have to have a perfect knowledge of enemy potential, and we will strategize for long-term advantages. So our study, we had about 40 eyes from 40 children, which were retrospectively analyzed. They were operated by 2 surgeons, both pediatric ophthalmologists. All children were less than 17 years of age at the time of presentation, and this was over the last 4 to 5 years. And we retrospectively analyzed and compared to what the literature said. So this is the guidebook that we came up with, that every trauma could be classified into open or closed angle, closed globe trauma. If there can be an anterior lens capsular breach, and there can be immediate presentation. In those cases, we did a repair of the corneal tear and lens aspiration only. And when it was delayed, we did lens aspiration with IOL implantation. And when the anterior lens capsule was intact, we did second surgery where we removed the cataract and placed it in the back IOL. So this is a little idea about how literature was different from what we showed. So our male to female ratio was more boys, 33 were boys and 7 were girls. And the mean age group was about 7.5 years. Both sort of matched what literature also showed. The time of presentation was within 1 week. And the cause often was penetrating injury with sharp objects. 67% of the cases were penetrating injury, and blunt was only 27%, which is also what the literature showed. So these are the different articles we went through. There was articles from all over the world, and often this is the article we use for cause epidemiology, and it shows that penetrating injury are quite common. Another article from Brazil. Then we had one from Ethiopia. We had saw one from China, Australia. So what about prognosis? Now we know that the OTS is a good score when we have to talk about traumatic cataracts. And there was an article in JCRS which suggested that OTS can also be used as a good score to see in children as well. What about the morphology? We know that traumatic cataracts can either, when ruptured anterior lens capsule will present with a soft white cataract, and when it's intact, these will be total membranous or rosette-like cataracts. And we also know the final visual outcome was varying according to the morphology of the cataract and also the surgical technique from this article. So in our study, we found that soft cataracts did better. Open and closed globe injuries represent a different situation in each time, and the time interval between the injury and the surgical removal of cataract is of important for determining the final visual acuity. So is the surgical procedure of choice, and most important thereafter is the visual rehabilitation. So I'll placement strategies. How do we get the IOL right? Various articles have shown that there is a myopic progression, and getting the IOL right is now slightly more difficult. But now putting an IOL is a routine thing in all traumatic pediatric cataracts, especially when the corneal diameter is sufficient and the length of the eye is perfect. So whenever there is a bag, the in the bag placement is the best idea with a single piece IOL. Whenever there is no capsular bag, look for a capsular support and place in the sulcus a 3-piece IOL. And when there's no capsular support, you can think of the new age SF IOLs in older children, or the retro iris pupillary claw lens also in older children. But always, tip here is always keep a backup IOL, because you never know what you will get. An article which compared the iris claw lenses versus the SF IOLs and said both did quite well as far as the glaucoma synechiae were spoken about. So neopremium IOLs is still a debate. There is an article about multifocal IOLs and unilateral cataracts, which may not be a bad idea in long term because these are unilateral cataracts. But again, very few number and very difficult to justify their use at the moment. We know the PCO formation is almost all kids will go through PCO. It's more so with traumatic cataracts. And the study showed in our study, we placed about 37 IOLs and 3 were left aphakic. 32 were in the bag placements. 29 were single pieced. 3 were 3-piece IOLs in the sulcus, and 5 of these was a sulcus placement of again sensor lenses, and 3 were left aphakic and had secondary implantation later. While power calculation, the keratometry challenge, because often the corneal tear is there. So we remove the sutures after 6 weeks of the corneal tear repair, wait for another 2 weeks and look for reliable findings. If there's no reliable findings, we look at the topography method or the contact lens method. In our study, we did use the topography method as well as the contact lens method in these cases where the cornea was badly injured. So whenever there's associated iris trauma, you have to look at the synechiolisis that you'll do. Iridodialysis will look after by double arm mechanism or even the 4-throat pupiloplasty method, which is currently in place. Secondly, we always made documentation, so it made us easy to make a decision on presence of capsular support after the primary surgery, and we planned the type of IOL accordingly, and we aimed always whenever we're doing the primary procedure also to make a PCO and make the primary visual axis clear so that there's no amblyopia thereafter. And capsular bag can be opened like in this case where primary surgery was done somewhere else, and we placed a 3-piece IOL in the sulcus. In conclusion, keep a VR surgeon with you, do a proper PPC in most cases and anti-vitrectomy in all cases. And whenever there is a scar, rely on the topography or over-diffraction CL method, and always counsel for surprises, and don't forget the visual rehabilitation thereafter. Thank you. So if we don't have any questions, then we can have our next talk, which is a Santin sponsored talk on levofloxacin. Dr. Reena will be giving us the talk.
Thank you, Dr. Aditya. Lovely seeing you, Lisa.
Rahul,
all right, can you see the screen now? Yeah.
Yes, we can see it.
So we're going to talk about the promise of high concentration antibiotics for the use in routine infections. So whenever there is an ocular infection, usually the current treatment practices, either it's empiric or it could be culture guided treatment. So empiric is the most common strategy which we use in our OPDs. That's when we use a broad spectrum antibiotic and we try and cover most of the organisms. It's indicated if there is more risk. Yeah. Okay. So just a second. Can I go to slideshow now? Is it still is cutting? Is it? Right.
I think maybe you continue presenting this way. The slides are pretty big anyway.
Now can you see it? Is that? Oh, sorry. Okay, okay.
If Kushagar is there, you can ask him to help you.
Yeah, yeah. Kushagar? They're just getting this part of the screen, they're not getting this.
Double click on the screen.
So first share screen.
Double click.
Can you see it now? That's fine. Okay. Thank you. Back. So whenever we're choosing our ocular antibiotics, what are we looking at? We need, number one, that it should have a good, strong penetration. It should have a good high concentration. It should have a fast killing rate, recovery from symptoms. It should be a broad spectrum activity. It should have a low propensity for developing resistance. It's very important because it shouldn't be such a low dosage that it causes resistance. And it should have a good safety profile for the patient. Now it's not moving further. So the MIC is used to select the antibiotic, but this approach has some shortcomings. So basically, we shouldn't see the MIC and then select our antibiotic, because what happens here is that there is no information of the bacterial killing rate with change in the drug exposure, because drug exposure is not constant. So that's why it's not very important to select it while just looking at the MICS. The MICS alone is not the potency of the antibiotic. So MICS is not static. So the static MIC approach does not reflect an in vivo scenario where bacteria are not being exposed to constantly changing antibiotic concentration. So this is one option. And making the right choice of ocular antibiotic is dependent on two factors. Number one is choosing the right concentration. And number two is the pharmacokinetics and the dynamics principle, which is the rational method of antibiotic selection. And number one, that's choosing the right concentration of an antibiotic. We know the fluoroquinolones are concentration dependent antibiotics. So the antibiotics can achieve faster killing rate if enough quantity is delivered in the infected tissue of the cornea. And we see there is higher concentration of the antibiotic, higher diffusion across the corneal or aqueous humor once the concentration is higher. But low doses or subtherapeutic doses of the same antibiotic, the fluoroquinolones, can cause antibiotic resistance. So we have to give adequate dosage. Now the PK and the PD, that is the pharmacodynamics as well as the kinetics concepts, is to understand the fluoroquinolone activity. Here again, we have to understand the Cmax and the Tmax, that is the peak concentration of the drug after the administration, and the time taken for that the concentration to maximize in the eye. So the drug is instilled, it's absorbed, distributed, metabolized, and excreted. So we need to check out what are the clinical effects, how much is their bacterial activity, efficacy, and what are the adverse effects of the antibiotic. Enhanced AUC at the MIC ratios, this is what predicts the antimicrobial efficacy in an antibiotic. And the enhanced Cmax and the MIC ratio is a predictor of the antibiotic concentration, and the bacteria are likely to develop resistance or not. So we need to study the ratio as well. The PK and the PD principle in a nutshell is that maximizing a concentration to maximize the therapeutic efficiency and overcome the resistance. So that is the important part. Higher concentration of antibiotic, it goes maximum to has a maximum tissue concentration. So the dose has to be optimized so that it is not less that it causes resistance, but it should be enough to
give you the maximum concentration in the tissue. So making levofloxacin the antibiotic of your choice in ocular infection management. We've tried levofloxacin in many of our cases of keratitis and corneal ulcers. We see that it has a fast action, good tissue penetration, broad spectrum activity, and it has a good safety profile. So once you've used levofloxacin 1.5%, it has a higher concentration as regards to the other fluoroquinolones also. It potentially resolves a bacterial conjunctivitis and keratitis within 1 week. It also depends on the area of the affected area on the cornea. But with day 3, the bacteria are eliminated almost 95.3%. This is what the studies have shown. The levofloxacin 1.5% exhibits greater penetration and prolonged activity versus the other fluoroquinolones. So when we do the study of levofloxacin, which is 1.5%, versus the gatiflox, which is 0.3, and moxifloxacin 0.5, and bacifloxacin. So this is the result. It has better penetrability as well. And when we see the levofloxacin 1.5%, it exhibits early and sustained penetration in the aqueous humor, the cornea, and the anterior vitreous. The concentrations are higher. Corneal penetration of topical levofloxacin 1.5% as a prophylaxis for cataract surgery. So preoperatively, we were giving more of moxifloxacin to our patients preoperatively, and it has been shown in this study that 1 hour, 2 hours, 4 hour, and 6 hour penetration of the same molecule, it has a higher penetration as compared to the topical moxifloxacin when instilled preoperatively in these cataract going patients. And it exhibits higher corneal penetration, and so the bacteria and potentially assessing bacteria in the anterior chamber are better targeted with this antibiotic. So this is the coverage of the levofloxacin as compared to moxifloxacin. The different aerobic, anaerobic, aerobic bacteria that are covered by these two antibiotics. You can see here that levofloxacin also targets the Pseudomonas bacteria, which is the aerobic gram-negative bacteria. Levofloxacin 1.5% was well tolerated in patients with bacterial conjunctivitis and bacterial keratitis. It has very less adverse effects, just mild in severity. And this is the incidence of different eye irritation, pruritus, urticaria, or allergies to the levofloxacin were not seen in our patients as well. So this is does not delay the wound healing. So this is the various graphs which shows the corneal epithelial cells, keratocytes, as well as the effects of fluoroquinolones on wound healing in corneal endothelial cells. It shows that it has a fast wound healing as compared to other fluoroquinolones. So it has higher concentration formulation. So the basic benefits we see is that it exhibits concentration dependent efficacy profile. Is the highest concentration of fluoroquinolone, which is 1.5%. It enables a Cmax greater than the MIC 1 to 3 and increases the bactericidal activity, inhibits development of resistance, and promotes increased concentration in the tear fluid as well. So OPHTHAQUIX is the name of the component that we have in the levofloxacin 1.5% by Santen. It's the antibiotic of choice in routine infections because of all of these effects that is causing it. See, the take-home message is that the fluoroquinolones being concentration dependent, hence are recommended drug class as a part of culture-guided treatment. And resistance to moxifloxacin and gatifloxacin is increasing. So we have more and more role of levofloxacin also maybe in the future in recommendation for our pre-cataract preparation of our patients. MIC has been used in to select the drugs, but it does not provide information on how much is the bacteria that are killed in the course of the effect. And the PK/PD parameters, like we already discussed, it is with the therapeutic effect, it predicts the outcome, and depends on dose, which predicts the efficacy and development of resistance. And it also supplements rational selection of the antibiotics. So, so this is what basically is our the after quicks is levofloxacin 1.5%. It is preservative free, and it can be used in your keratitis or conjunctivitis, and you have early recovery of these conditions also. Thank you very much for your patient listening.
Thank you so much, Dr. Reena. I think Dr. Lisa has a question.
Yes, my question is, it's self-preserved, I presume, since it has no preservative, just like oxafloxacin. Vigamox, has been used intracamerally, even though that's off-label. That's something that I used from about 2005 on in every routine case intracamerally, following Steve Arshenov's original work. And I wonder if anyone has commented about this particular formulation. Whereas Vigamox can be used intracamerally, Maxiza has the wrong diluent and will cause horrible TAS if you use that intracamerally. And I wonder if there's any data or experience with this drug.
No, there isn't any data as such for it's being used as an intracameral dosage. I mean, I've been asking, and that's exactly why I was, a little skeptical about having two antibiotics for the patient, like one preoperatively and intraoperatively putting a Vigamox. But we are using more and more for keratitis, conjunctivitis, and we've had good results in corneal involvements and corneal ulcers, bacterial corneal ulcers. But we haven't yet seen any study which shows that it can be used intracameral.
There are several safety studies for moxifloxacin, for Vigamox. There are several in the literature. So I wondered, yeah. Thanks.
The company contraindicates levofloxacin for intracameral use.
So does the Vigamox say that, yes. But there have been many studies that show that it's practical and safe. One of them was my study in the JCRS looking at macular thickness.
And I think one of the largest studies was just published from Arvinda Hospital in the same. Intracameral moxifloxacin.
At Haripriya, Haripriya showed Haripriya, of course, Haripriya at Aravind, and David Chang, showed incontrovertibly, really, with 2 million cases, that it wasn't prospective randomized trial, but it was, incredible record keeping, and I can't see how anyone wouldn't be using it. So that's why I wondered, I wouldn't want someone to use this preparation if it's, for example, Maxiza is a disaster. So, that's why I asked the question.
So talking about Vigamox, we have talk on its cousin brother Vigadexa from Novartis.
Yeah, and we don't have the oral lab in the United States, so to get a legal a totally on label from compounding pharmacies is almost prohibitively expensive. So it's a pretty crazy catch-22 in the United States.
But it's cheaper than getting the Vigamox.
Oh, yeah, the Vigamox is the way to go, except that it's off label. So medical legally, it's an issue.
Let's open up the podium for a quick 2-minute discussion before we close up this module. The next session will be a sponsored talk by Dr. Aditya. So any questions? I can put forward something that I would like a comment from each one of you over here. What would be your go-to formula for pediatric cataracts?
I think the study that has been published by recently, in fact, from LBPI was about SRK2 being the most widely used and the most accurate formula when it came to pediatric cataracts. And I think I personally use the same. Even though we have the Barrett's calculator, which has done quite a good job there as well. And it makes it a little easier. You just have to put your residual power. You can just mention, say, if I want a 2-year-old to have a +5 or a +5.5, I just mention that and it gives me the power. So I don't have to do that little digging that I normally do otherwise.
That's in the Barrett's formula.
Yeah, in the Barrett.
So your study which you're quoting is an old study or is it a recent study?
It's relatively recent. I think 2012, if I'm not wrong, or 2014 or 15.
So I think Barrett's had become more popular later as well. I think.
Pediatric cataract, I think people are still traditional about it. So yeah, SRK2 still trumps. I don't know, Shell and Dr. Lisa and Dr.
I think there's no consensus as far as pediatric IOL formula goes, and that also comes from literature. You know, from in our data which we published, we found 4 years back, we found the SRKT, sorry, and the Holiday 2 to be the most accurate in our database, and there are several conflicting reports. So pediatric eyes are, they don't behave. No two bilateral cataracts, and it depends whether it's a bilateral cataract, unilateral, what age, so on and so forth. So as far as I'm aware, there is no literature with the newer generation formulas like Barrett Universal and Hill RBF. We are in the process of analyzing with the Barretts, but as of now, I think everyone has their own choice.
There's a very nice article in IGO by Dr. Khokar, where they've used their data and they've analyzed it and compared it to the European eyes and the American eyes. And they said the Indian eyes, they don't need so much of a undercorrection comparatively.
Do you have any experience using ray tracing for pediatric eyes, for pediatric cataract surgery? Do you have any experience?
No experience.
But that might, to me, ray tracing would be the most exact way.
The problem with pediatric eyes is that many of them, the measurements are taken under anesthesia with suboptimal instruments like handheld keratometer, immersion ultrasound, so on and so forth. So there are a lot of limitations as far as pediatric eyes go.
Handheld keratometers also, I don't think any company is really making it. We have a couple of them from China. There was one Nidec one which is no longer in production. So a lot of issues there as well. We're getting that right.
I defer to all of you with that, but one question I would ask related is, what do you aim for? Because we know that, we know that the eye is likely to grow, but we don't know how much, and there's so many factors affecting emmetropization, and the real reason we're doing this is to prevent amblyopia. So, if you go too far plus and they don't wear the correction, then you haven't achieved your goal of preventing amblyopia. So I wonder what you all tend to aim for, because I tended to let them go myopic, but during the amblyopic age period, I wanted it to be something that would not be an amblyogenic correction. So depending on the other eye and whether it's unilateral, trying to match that, getting them in glasses that work with two eyes is really the point, I think, in the beginning, to me. And then, of course, we have many options when they grow up, and they become myopic. So I wonder what you actually aim for. So many people aim for hyperopia, and I don't quite get that, because you're just a total guess as to where it's going to end up anyway, and why not, why worry about the amblyogenic effect of being hyperopic now, especially without presbyopic correction?
I think, ma'am, to answer that, there are a lot of factors which come into play. If it's unilateral cataract, then you will look at the other eye refraction, then decide. If it's bilateral cataract, then generally the norm goes that you aim for hyperopia to accommodate for the myopic shift, which will definitely happen either which way, as studies say. But yes, there have been talks about correcting them if they become too myopic by doing LASIK or PRK or contact lenses thereafter. But again, in India, the thought process still goes that glasses are well tolerated by children as compared to, say, contact lenses or lasers or refractive surgery. So we tend to keep them hypermetropic, give them amblyopic treatment, and then see them as age goes. Often we miss them and they come as teenagers. And they come as teenagers, they come as a -11, -12. And
that's a good reason to keep them ammetropic to begin with. So if they don't come back, you haven't got an amblyogenic factor.
Yes.
You also have to consider the parents. If the parents are myopic, then also you'll know that the trend is towards myopia. So while calculating, you need to keep that in mind.
Thank you so much, everyone. I think with this, we will conclude the session. And thank you so much for this contribution. And the smaller group usually always has a better discussion. So I enjoyed. I hope all of you did too. So we'll close this module now. Thank you, Dr. Lisa. Thank you, Dr. Shell, Dr. Sibyl, Dr. Reena, Dr. Aditya. So next
Thank you. It's my pleasure.
Thank you.
Thank you.
Hey.
Thanks.
So we have a Novartis talk now on the newer paradigms on post-operative management of ocular surgery, combating infection and inflammation both in one go. There is a financial interest that Alcon Laboratories has given this sponsored talk. So we know the cataract surgeries are increasing with time in India, and with increase in number, we need to improve quality because we know that we need to deliver. So cataract blindness and surgery projections are just shooting up with time. And prevalence of complications associated with cataract surgery are also increasing. And 1.5 million of the 6 million cataract operations in developing countries have poor outcomes from a study from Eye Health Journal in 2008. And most common medical complications are either infections or inflammations. So when we talk about infections, we're talking about endophthalmitis. We know that India has a low rate of endophthalmitis as compared to the US and in Europe, as per this study. We also know in UK, the most common cause is staph epidermis, but in India, it's nocardia. So a lot of light is being shown to gram-positive bacteria. About 69% of these infections are gram-positive. And in India, 65% of them had vision of less than 6/60 post endophthalmitis. So the method of prophylaxis could be preoperative, intraoperative, and postoperative. And we know moxifloxacin has been the trustworthy antibiotic to prevent this infection. So it's the 4th generation fluoroquinolone is ideal for this situation. When used in proper manner, it also there can be less chance of resistance to this. Potency of moxifloxacin against gram-positive, we know it's highly potent for most of the gram-positive pathogens, as compared to its brothers ciprofloxacin, gadifloxacin, levofloxacin, ofloxacin. And we also know that for Staph aureus, it's one of the most potent ones and has the greatest potency gram-positive MICs than even gadifloxacin in aqueous humor. As compared with other fluoroquinolones, it has most potent as compared to the older fluoroquinolones, and greater potency with moxifloxacin has been seen for Staph aureus and coagulase negative staph also. We also know that moxifloxacin kills Staph aureus faster in vitro than the older generation of the antibiotics. When we talk about inflammation, we talk about early complications like posterior synecdoche block, raised IOP, and late complications of PCOCME. So peak of signs and symptoms of inflammation are seen after 2 weeks, and topical anti-inflammatory treatment after modern cataract surgery elevates the inflammatory response and possible risk for complications such as corneal damage and CME. So corticosteroids or NSAIDs, that's what we talk about. We know that corticosteroids are the mainstay here of treatment, and wider range of activity as compared to NSAIDs, and reduce the inflammation at multiple points in the inflammatory cascade. Like in this slide, almost no inflammatory symptoms were found after post-operative administration of dexamethasone. So it's often the best steroid used in combination with antibiotics. So when we compare it to prednisolone, which has slightly less potency than even dexamethasone and lower binding capacity, so that makes dexamethasone act for a longer duration. So a combination of both of these, moxifloxacin and dexamethasone, or something that prevents infection as well as inflammation, will improve patient compliance with treatment because it's one drop for both reasons. And combination products reduces the cost to the patient. It decreases the complex system that we devise for dosing, and increases likelihood of receiving proper dosage at proper times. And it positively impacts clinical outcomes. Also, you don't have to tell your patients that you have to put 8 medicines after surgery. You can just say you have to put 3 or 2. So one medication, the compliance is much more, as we know. And Vigadex is one of these combinations that we talk about. It's the first and only self-preserved antibiotic steroid combination. and pH is about 7.8, and the dosing we all know about. So efficacy and tolerability of this combination is not only reduces the inflammation, reduces chance of infection, also increases compliance. So a study was done to compare this with other, and they found out that the group that received Vigadexa as compared to those who received Moxi and Dexa separately did much better. And as far as the pain was concerned, the pain was equally less or slightly less in the Vigadexa combination as compared to the others. And visual acuity also did equally well as compared to two separate medicines. None of them also had inflammation after on day 15 in both the groups. And there was no reports of itching with Vigadexa by day 15 as compared to there was reports of itching when there was not when there were two medications. And the anti-itch chamber was much quieter with Vigadexa as compared to separate medications, and IOP also was well controlled. So a single vehicle fixed dose combination was found to be well tolerated and therapeutically equivalent to conventional separate dosing of antibiotic and anti-inflammatory. So it is the only self-preserved combination, has back in it, and this is a slide talking about how it's made and what the testing is done. So size of the drop also affects, and we know that the bottle dropper, which is Novartis is patented, gives only one drop at a time. So having same, how does it compare to generic medicines of the same value? We know that there is a lot of difference between the two because there's a lot of R&D designing which goes behind these medicines, and there is quality which comes with these brands. In conclusion, it's a safe fourth generation FQ moxifloxacin, and added these anti-inflammatory benefits of dexamethasone, and it's only self-preserved combination, well tolerated, comfortable use, and improves compliance and adherence to treatment, and gives the same result as we would have had otherwise. Thank you so much.
Thank you so much, Aditya. Any comments from any of the panelists, any of the participants?
Aditya, have you ever had patients after 2 weeks of giving of Vigadexa complain of some redness, irritation, like a rebound irritation, and like just stop it post-operative?
After we stop it, you mean?
Mm-hmm. Yeah.
In 1 or 2 cases, yes. There has been. So often we give a tapering dose as well for about a few days and then stop it completely. So ideally the 4 times a day for 2 weeks, and then maybe just reduce it for another 5 or 6 days and stop it.
Yes, Dr. Lisa.
I'm curious because my concern about the combination is that you may want to taper or keep your steroid longer, but you don't want to do that with an antibiotic because you're going to induce resistance. So to me, I mean, you wouldn't use an antibiotic any longer than a week, but you're probably going to use a steroid longer than a week. And there's really no data for tapering steroids after cataract surgery. You know, there certainly is when there's an ongoing problem like uveitis, but when it's a one-time, event, assuming a clean eye, I used to just keep it up and then quit, but I would certainly keep the steroid longer than the antibiotic. So how do you propose to deal with that and not create resistance by continuing to use the antibiotic beyond where it's appropriate or needed?
So I think there's a thin line there, and you can stop the combination and continue only with a steroid thereafter. Or
then you have to give them a second bottle, and that's expensive, more expensive. So that's why I wonder as to the efficacy of the combination for cataract surgery.
So I think in most cases, just a combination is good enough. But in those cases where you need to continue steroids beyond a particular time or the recovery is not made, I think a second bottle of just a steroid would be a good answer, because here you're fighting for compliance as well. The burden of putting drops, remembering your drops, not missing a dose, that also plays a lot on recovery post cataract surgery. So I think when that is concerned, this outscores the 2 separate medications. But on the other hand, the conventional way of having your steroid separate and the antibiotic separate pays dividends also. But again, it depends on the personal personality and the choice profile.
Encouraging resistance is my main concern. Yeah.
Yeah, but ma'am, I think it has a little relevance when it comes to the Indian scenario, since we do patients from villages. There's a lot of loss to follow up. So yeah, and even the lack of education. So in these patients, I think fixed combination drops work better because there's more compliance to them versus too many confusing regimens. So that is one advantage. And second advantage, of course, is, let's see, they're usually going to finish off a bottle in maybe 2 weeks or so. Thereafter, only the steroid drops can be continued. And also one must remember that it's not just the post-operative period that the indication for Vigadexa is. You can also use it in other situations, for example, after a YAG capsulotomy.
Sure.
So yeah, so there is that.
Then you don't need the antibiotic.
Right. So YAG capsulotomy, again, something that we were talking
Secondary post-operative endophthalmitis can happen. So it's advisable to use an antibiotic along with the steroid.
Yeah. Just to prevent that secondary low grade endophthalmitis that can happen post YAG capsulotomy.
So I think we'll have to now round up the session because we went past our time. And we would like to thank Dr. Lisa Arbisser, the guru of Dr. Reena Sethi and the mentor, who comes in every year and gives us such nice views. And we hope to see you next April in Washington, D.C. if they allow us to enter the United States. Lisa, please convey our best wishes to Amir for a quick recovery. And believe us that all over the world, you're now known as a part of the extended Sethi family as the matriarch. So we look forward to you for putting in and helping us out. We now have a little presentation from the Commissioner of Gurgaon. After that, I request Lisa to give the vote of thanks and conclude the session. So the presentation from Mr. Rajiv Ranjan, Commissioner of Gurgaon, is coming on now. So Lisa, please make sure that you listen to that and give us a vote of thanks. Thank you.
World Sight Day. I welcome you all for this nice discussion. Although World Sight Day goes for universal access to the eye care facilities, but practically this is not possible in third world countries and many other countries where awareness and accessibility both are an important issue. However, in Gurgaon, we are experimenting with our new campaign. The campaign is called the Campaign Eye Care Gurugram. And in this campaign, we try to reach to those persons who are unable to afford any hospitalized health care for their eyes. We are also trying to generate a massive awareness program so that we can reach each and every nook and corner of the Gurugram city, so that we can identify whosoever has even the minute case of any problem or even potential problem relating to his eyes. Because unless we can identify and then we can start treatment of such problems, then only we will be able to solve all these things. And the actual motto of universal health access to everybody will be achieved. For this, we have taken partnership of 5 different NGOs, which are Arunodaya, Venu, Arvir, Niramaya and Vivekanand. These NGOs work in partnership with Government of Haryana, and they provide camps, they identify the diseases, they check the eyes, they even report us all the eye cares and surgery related requirements. We have a software where all these data are fed and it is monitored also in a time bound manner. Whenever a person is identified with any problem, the solution is given. If it requires a surgery, then he has given an option of come to some date in future where he can go for surgery. If there is some rush in surgery, then he could be given a later date also, and two-way communication is there between every patient and the healthcare provider hospitals. All these NGOs are working tirelessly. In every week, we are going for 20 camps per week, and most of the camps are, not all camps, but most of the camps are in the PHC, primary healthcare centers only, where people anyway go for their routine medical checkups and other health related problems. That is why we are progressing at a very high pace, despite this was a COVID year and almost whole the year was affected by Delta variant and some other problems. Still, so we are able to get very good progress, and more than 10,000 patients are already benefited from this program, and much more are going to benefit it. Our vision is that healthcare should be not only affordable, it should be accessible to everybody, it should be quality care, and there should be enough awareness so that nobody should face any problem in his health, since because he doesn't know and doesn't thought it fit to get it checked. And we expect that by the time of 1.5 years from the now, we will be able to completely eradicate any problem already existing. Ongoing problem may continue to be treated like it is treated even now, but all the backlogs are there that will be cleared, and I think that will be another model worth a study all over the world. Thank you.
Thank you very much. I now request Dr. Sheer M. Amirzada from Afghanistan, who is holding fort in Afghanistan after the US has left, to please say a few words about his impression of the webinar. Your voice, audio, come closer.
Okay.
Good.
Thank you very much from family to invite conference. I'm very happy to join with you.
I now request
Thank
Dr.
you so much.
Thank you. I request Dr. Sahiban Sethi to say a few words to conclude the session.
Way crossed our time, but this was really wonderful, and I think it was a very healthy discussion that we all had. And thankfully, we did stay back for the discussion. We do have a few audience questions that we can probably personally email to the speakers. And thank you everyone for being a part of this. Yet another a global successful webinar concluded. And thank you, Dr. Arun and Dr. Reena Sethi, for spearheading this and getting us all motivated to do this. It was a good, fulfilling day. Thank you, Dr. Lisa. Thank you, Dr. Sybil, and Dr. Amirzada, and everybody who joined us today. Thank you.
Request Dr. Reena Sethi to say a few words, and then Dr. Lisa Abisa will give the vote of thanks.
Thank you. Thank you very much. It's been such an incredible evening today for us, evening and the morning for you, Lisa. Number one thing that we could see most of our friends here like last year. And the other thing is that, it's so nice to see that we can keep up with all what is happening latest in ophthalmology. And we look forward to many more such meetings in the future. I think, thank you very much for all the participants to be a part of our pan ophthalmology. Thank you.
Thank you so much.
Dr. Lisa, please.
Yes.
You're muted. Now you can come forward and speak.
I don't think I'm muted. I think I'm unmuted. Are you muted? Okay.
Is Amir there?
Oh, I can grab him, I think.
Yeah, that'd be wonderful.
Amir, please come. He's on his way.
Great.
Hey, babe. Quickly.
We're looking forward to meeting Amir on screen after a long time. And Amir, there you are. Welcome. Yay.
Hi.
Look at him walking well.
Yeah.
Welcome, Amir.
Yeah.
Yeah,
We're all doing well.
Meet our younger daughter-in-law, Dr. Saiban Sethi and Dr. Aditya. They'll be seeing you in New York next year in April.
Hopefully.
We certainly hope so.
We'll consider it.
And if you come, I mean, we would love to host you in some way if COVID allows, and you know, it would just be great to get together.
We are planning to float in the Hudson River just to be away from COVID.
And we're delighted at the growing family, that you're beautiful, dedicated, growing family. It's just a real inspiration, really. You guys are so innovative and constantly, you know, at people's disposal, and it's an amazing thing in this world. It doesn't happen much. We're proud to be a piece of it.
Thank you so much.
I'd like Amin to say a few words good about us.
He really has to say.
You want to say a few words about them?
About that. Yes, I think that Arun would look very distinguished if he had a.
I know, I've been telling him that.
And then join the club.
Yeah. Correct.
You know, I had patches of alopecia, so I can't do that.
Well,
Amir, how are you
lovely.
feeling after your surgery?
So great to see you, Amir.
Straight now.
He's just doing great.
Yeah, wonderful.
You know, in India, wives don't allow husbands to go through the surgery because it makes them stiff back.
Well, we had a wonderful surgeon. He had a 3-level decompression and a 1-level fusion, which really was, I think, the right choice.
And a 5-hour party in the OR.
Yeah, it was really a blessing, though. Yeah. So
And we're looking forward to hosting you both in India when you come next, and we're going to take you to some of the most exotic.
I hope that time will.
India's pretty safe
probably
because
see you first here.
nobody wears a mask, so you can't catch infection.
Wonderful. Well, all right.
Thank you
Well,
once
say hi
again
to
for
your
coming,
brother,
Lisa.
please.
It's a
that?
pleasure. And thank you very much for coming
Thank you.
on.
And maybe Seban and I will publish this little thing. And I've got more ideas too, if you're into it.
Yes,
You know,
and you'll be happy to know that we're coming up now with a project in a 1.25 acre plot to create a multi-specialty facility.
Amazing.
And something for recovery of people in elderly age groups. And we're going to have you and Amir come in to inaugurate the elderly age group
and maybe
section.
we'll really get a photograph of Talia's. We'll see.
That's right. We do. No, we will.
It was a cute idea.
No, we're going to put Talia's photograph in the hospital. We're just waiting for the painting to get over. I'll show you with the camera the new colors on the wall. So you get an idea.
There you go.
And
your baby's doing great.
We see Venice.
I don't know, whenever you go, it'll be Venice.
Yeah, we had Venice and the Taj. Venice and the Taj. How can you do better?
The beauty of having
Okay.
this curtain is that, as Dr. Amir Zada would agree, I've never been to Venice, so we have curtains to keep ourselves happy. So, Amir, next year we're going to have you sing songs on the webinar.
Okay, I'll look forward to it.
Good night, and thank you very much, and enjoy your day in New York.
I invite all of you if you want to come to Kabul.
Yeah, not now. Little later.
Yeah.
And we'll have Lisa and Amir come down to Kabul to say hello to the Taliban.
Now,
What a sad situation. What a sad. Oh, we
I hope
just
you're
been
safe there,
watching
Dr. Shir. Are you safe?
with broken hearts.
The situation in Kabul is fine, but there is no money. You know,
Well, the banks are closed, right?
Right.
The banks are closed, and that means food is closed for so many people.
Don't worry, we're sending Joe Biden to Kabul to settle things for you.
The problem is there is no money. Every person has money in the bank, but cannot get money.
Cannot get
bank.
them.
Can't get it. Yeah.
Bad chance.
It's a sad situation, but keep up the good work that you're doing for the poor. And Team
Yes.
Arunodaya will support you through Lisa and Amir anytime you need.
And our prayers are with you, really, and your country.
Stay healthy.
So sorry how that ended.
Good night, and we now go back and celebrate. Tomorrow is the festival of the Shera, when we burn the effigies of evil. So we'll put one of Taliban next to the 3 gods, and then we'll do it. Bye-bye. Good night.
Good night.
Good night. Bye.
Bye.
Bye. Bye.
Be in
Good
touch.
night. Yes.
All right.
Okay.